It's nice to see everyone mixing, isn't it? Lovely. Okay, well I think this is going to be a variable level, hopefully. I'm going to try and make it accessible for everybody. There will be things that might be a bit harder to follow for different year groups, but we'll see, obviously depending on everyone's backgrounds. So specific objectives, what I'm going to be talking about today, going into what advanced life support actually is, putting it into context, why we do the things we do, hopefully clarify a few grey areas there, talk a little bit about the critical illnesses that need advanced life support, and develop some awareness about the definitive care that is provided for these patients. So that's the kind of thing that isn't found in the average ambulance. Throughout this, I'm going to be talking about the various medications that we use in a bit more detail, but please, use some unsubtle body language if I'm boring you. We are mostly going to be tying things into cardiac arrest management. That is what most people think of when we say ALS, but it is not the be-all and end-all in the ALS world. So the patient assessment model for ALS is the model that hopefully everyone's at least got some passing familiarity with. Dr. A, B, C, D, E. Is everyone comfortable with what those stand for? They are on the board, just in case. Yeah? Lovely. So as we're going through our A to E, as they like to call it in hospital, it's appropriate to do some basic things to correct problems in order to facilitate further assessment and treatment. For example, using some basic airway skills to allow you to examine breathing is appropriate, whereas stopping to intubate the patient before checking if they're, if they've got a pulse or not is probably less appropriate. The one exception to the A to E assessment is massive catastrophic hemorrhage, where we're going to be looking at direct pressure and or tourniquets going on before we do anything else. What is catastrophic hemorrhage? Does anyone want to try and stick a number on that, what it actually is? There's a really easy way to think about it, and that's hemorrhage that's going to kill you faster than an airway problem, which is why we correct it before we correct airway problems. So these are the guys who are going to bleed out in the next few minutes, and whatever else you do, you've got to get that hemorrhage under control first. I'm not talking about trauma much today because it's a separate paradigm, but that's a little mention to be aware of. Now when we're actually delivering ALS, it's important that we have a good foundation of our BLS skills. The BLS mostly consists of doing CPR, attaching an AED and using it, and maybe a bit of A and B, depending on your BLS provider. Who's going to be your average BLS provider outside of a hospital for most cardiac arrests? The first person on the scene. Who is it usually? It's either nobody or bystander. Yeah, bystander CPR. Doesn't matter if they get the AED on a bit funny or if they're not doing very good CPR. Is that important? Not really. Anything's better than nothing. We know that. And this guy is the one who's making a real difference. Nothing I'm going to bring to the scene is going to help if he's not got his... I was wondering that. I was going to say person. I've let myself slip.
Maybe they don't identify.
And if the person's got any familiarity, they might use something like this to deliver a little bit of A and B. But this bottom of this pyramid is what everything else is built on. Chest compressions and early defibrillation, AED or not, something to shock that heart if it's fibrillating. That's what really helps these patients. The rung up from that is your intermediate life support. This is the kind of thing that's going to get delivered on ambulances without paramedics because they don't have access to the advanced care, but they know how to do the BLS and do it well. There may be some elements of ALS making their way in here and there. They're going to be good at using defibrillators and aware of what rhythms are shockable and what aren't. Very high quality chest compressions is the hallmark of a good ILS provider, and ventilating safely, so not just bagging in nice and hard every 40 seconds or so. It's good, effective ventilation that minimises interruptions to CPR. With medications, there's some legal issues, there's some local policy issues, but there might be access to some medications, and when we're talking about medications for patients who aren't in cardiac arrest, we're looking at things like aspirin, salbutamol, simple pain relief, the early treatment that might be helpful for these patients. In the real emergencies, they do have access to a number of medications, and these are the kind of drugs that you can give as a student paramedic. Are you all familiar with the Schedule 19 medicines? Things like IM adrenaline, hydrocortisone, atropine is actually a Schedule 19 medicine, although probably not in student paramedic practice, unfortunately. But there is that list of medicines written into law that anyone can give for the purposes of saving a life in an emergency, and ILS providers tend to be very aware of that because they don't get much to play with, so they know what they can use and when to use it. We're seeing increased availability of supraglottic airways for our ILS providers. Can anyone think of the key example of the supraglottic airway out there at the moment? Sorry, did someone say something? What's that airway device that we all love?
An eye gel.
An eye gel, yeah. So that's a supraglottic airway. It sits above the opening to the airway, but it's dead easy to put in, and it's an extremely effective device. It's suitable for most cardiac arrests. And ILS providers increasingly have access to them. This includes police medics. This includes almost everyone who works on an ambulance these days, as far as I know. Finally, it's important for your ILS provider to have awareness of what ALS is and how they can help deliver it. As a student paramedic, you're going to be at varying levels with your life support provision. As you get towards the end of third year, you're sort of halfway between ILS and ALS because you know how to do all the ALS stuff. It's just an issue of what you're allowed to do and what you're not. But hopefully this will help you all to increase your awareness of ALS, and for those of you who are going to be delivering parts of it, maybe open up a few windows of curiosity there. So my idea of what ALS actually is using advanced technical and non-technical skills to deliver critical care with a solid foundation of BLS and or a bit of ILS. We love ILS, but it's not always there, unfortunately. Does everyone know what I mean by technical and non-technical? This is a really important distinction that I'm going to be coming back to a lot today. A technical skill is something that takes a bit of brain, but mostly takes a lot of handiwork. This is your things like airway management, CPR, using a defibrillator. Non-technical skills is what makes ALS what it is. This is the stuff that you can't really learn from being talked to about it. You need to do simulations, you need to do training, you need to go to your lectures. These are your communication skills, your leadership skills and everything. This is the stuff that I'm really going to be hammering in on this lecture. So who do we provide ALS to? There's an obvious answer. Can anyone think of it?
Dead people.
People who are nearly dead, yeah. Dead or dying, fair enough. Cardiac arrest. If BLS and ILS aren't doing the trick, because we're never going to start with ALS, we're going to start with BLS skills, whoever we are. CPR and defib are the first thing to go on. And if that doesn't do the trick within the first couple of minutes, we're going to be looking at going up that ladder into the ALS territory. In terms of what actually counts as ALS, it's a bit vague. My opinion might be different to other people's, but most ambulance trusts consider ALS to be the moment at which you've got circulatory access and an advanced airway, so you're able to deliver whatever care you need to deliver, in theory. My thoughts on the matter are a little bit different to that, but it doesn't really matter because what I do with that information is very different to what they do with it. We're going to be providing advanced life support to our ROSC patients and to our peri-arrest patients. I'm going to go back to the distinction between those two in a bit. And finally, this nice little catch-all, medical emergencies that require a team to deliver effective care. That's a lovely, vague statement, isn't it? ALS is all about working together. You don't ALS by yourself. It's a very unusual situation if you're finding yourself doing that. When you're running that team ALS style, you'll feel it. You'll know that it's ALS. And that's what this statement is all about. Those situations that a normal ambulance isn't quite enough for. What do we actually need to get ALS going then? What's the most important thing on that list for any ALS situation?
The appropriate size team.
Yeah, the capable, appropriate sized team. I would certainly think so. All that equipment, you're not going to be using that by yourself. All those skills, you're not going to deliver them all at the same time. You need that team, and you need to know who's doing what and whether they're happy and capable of doing what they're doing. The non-technical skills that are really key to delivering ALS are having that knowledge and awareness, which is the kind of thing that hopefully you'll pick up a bit of here and go into your lectures and so on. Leadership and communication skills, which is a refining process that hopefully those of you going into your third year will be working on today, or this year rather. And understanding when basics are appropriate and when it's actually appropriate to escalate. Intubation is the infamous example of that. I'm not going to be talking about it in great detail, but I'm sure those of you who've been to arrests can imagine there's always that little bit of an argument, internal or external, about what the airway actually needs. Equipment-wise, defib monitor for us, that's the life pack generally in our ambulances or a Zoll or wherever you work. Usually the same device, thankfully. airway and breathing equipment, circulatory access equipment, and medications. All of this is useless without chest compressions, including the defibrillator. So the most important thing physically is whoever's got that good pair of working hands and arms on the patient's chest. There's that little pyramid again, BLS, foundation of ALS. That pyramid subdivides more and more and more, but chest compressions are always at the bottom. Everything else is on top of the chest compressions. Characteristics of people in your ALS team. They need to have a certain amount of bandwidth. Everyone's got this. Everyone's got that awareness of what's going on around them. People have just got it in different measures to one another. So how can we facilitate the appropriate bandwidth for the situation, where you can assign the right person to the right task? Someone who is clearly cacking it and not having a good time, but they'll happily perk up and jump on the chest if you need them to, because that's easy. They can just focus on what they're doing there. Grab them on the shoulder and say, right, get off now, mate, before we shock you. But someone who hasn't got that much bandwidth on the chest, good job for them if they know what they're doing. Someone who's got a bit more bandwidth, that's the kind of person you can assign your complex tasks to. So think about who you're putting on the airway, think about who you're putting on the drugs, and who's on the monitor. Who's going to be the team leader if there's more than one person to choose from. When we're communicating with each other, preferably we're using each other's names. That's the handy thing about our shirts. Unfortunately, you students aren't blessed with too many of those anymore. But you have got those lovely name badges, so please do wear them. Verbalising. Speak out loud, think out loud, do stuff out loud. Make sure everyone knows what's happening to you if they need to know it. If you're on the airway and you can't see anything for the tongue, the team leader needs to know that. If they need to escalate the airway to someone who's going to be cutting a hole in the neck, they need to know that, and they need to know that 2 minutes ago. But if you're just saying, all right, I'm twiddling my thumbs in the corner, that's not helpful verbalising. If you're coming up to your 2 minutes on your chest compressions, verbalise that. No one else knows this if you don't say it out loud, because everyone's got limited bandwidth, everyone's focusing on their individual tasks. With capability, we need to make sure that everyone's doing the right stuff for them. They've got the right training and knowledge to deliver it properly. If you are going back to airway, if you're assigning someone on the head, make sure that they know what they're doing and that they've got the necessary equipment with them within their scope of practice. And that team leader, is that the right person? Be prepared to say to the leader if you think, are you struggling here, do you need some help, do you want me to take over? But also be prepared for someone to challenge you as the leader. There's a difference between having a sensible discussion about leadership and being a bit of an arse. Hopefully I don't have to explain the difference. Hopefully we're not going to have to make that distinction much, because culture is changing in the ambulance service. People are becoming more receptive to leadership and becoming better followers. And I've never had a problem with a student myself in that context. So keep up the good work, guys. When you are the leader, you need to make sure everyone knows that. You don't necessarily have to say, right, I'm in charge, but stand in the right place. Make it clear who's calling the shots. Make it clear that you are being decisive. You are the one who people need to listen to, and you've got that awareness of what's going on. Remain calm. If you're panicking and you see the person in charge panicking worse than you are, is that going to help? Probably not the most useful thing in the world for someone who's already under a bit of stress. So if you've got that leadership position on your shoulders, try and ensure that you at least look calm. We're all a little bit tetchy at arrests, I think that's fair to say. But if you're in charge, then the team is relying on you to keep it together, and that means your emotional state and everything needs to be stable. Who should be a team leader? So if you picture resus with 6 random ambulance people on it, who are we going to have in that leadership position? Any ideas? Who said that? What did you say?
Whoever feels confident.
Whoever feels confident. Okay. Any other thoughts?
No,
It will be the highest sort of, so if it's a CC, it depends who's first on the scene. Because if you've got a paramedic there, that's already managed the scene, and then you've got a CCP coming 10, 15 minutes later. I feel like a good CCP would ask the paramedics what they need and what they want from them, rather than controlling the scene.
But if that paramedic isn't necessarily aware of everything the CCP can bring to the job, what problems might that cause?
He needs to communicate that and say
Yeah.
confident.
Yeah, be aware of different people's scope of practice to an extent, but you're never going to know everything. You're not going to know everything about that individual. I think it's very task dependent. I wouldn't shy away from putting the right ECSW in the leadership position if appropriate at certain times, because if we've got to the point in the arrest where we've got a definitive airway, we've got the drugs going, and we've done everything that needs doing, but someone's on the phone to top cover and I'm the only paramedic, I should probably be on that phone. Would you mind just making sure that we check the rhythm every 2 minutes, someone's interpreting the rhythm with you, and that we get the adrenaline done? Just let me know in about 4 minutes when we need to do adrenaline again. Yeah, perfect. That person, if they've got enough bandwidth, if they've got the right skills, which a lot of our experienced colleagues will have, there's nothing wrong with doing that. When it comes to making decisions like whether to terminate resuscitation, that becomes a legal problem at that point, and that's the kind of thing that you're not going to be delegating. That's the kind of decision that you need to be making if you're the paramedic at the scene. When you've got someone who's senior to yourself, as Maz had mentioned, with CCPs being a good example, then you have a similar kind of problem going on there, because if that CCP is the best ALS provider in the room, then they're a natural fit for the leadership role. But if that patient's got a really severe airway problem, or they need to have their chest decompressed definitively or something, the CCP is the only person who's going to be able to do that. They need a leader to run things in the background. I'm part of the Brighton Marathon medical team when I can be, and there's a very, very senior team there that do advanced life support. It's made up of, I think, 2 consultants and 2 registrars, but they only do a surgical procedure to assist with the resuscitation. They don't have anything to do with delivering the ALS. They leave that to the paramedic who's at the scene already when they arrive. So don't be afraid to ask the senior person, do you need me to take over while you do that? I remember my first job actually at SECAmb, my first cardiac arrest job at SECAmb. The team leader was on the airway when I came in, and he was clearly flapping a bit because he had way too much going on. But because he was a bit more experienced than me, I decided to put him in charge. Turned out that wasn't the right decision, but that was more to do with the individual than the actual situation. But the team leader doesn't always have to be the biggest name in the room. It depends on the task at hand. So here's a scenario for you, just written down on the side here. Read through that and then think about some of these questions on the side here. So you've turned up on your car and there's this crew dealing with this patient. What sort of things do we need to be thinking about with these questions on the side? So there's quite a few things going on there that we can look at. In terms of what tasks need to be completed, I know what my priorities would be. What about factors affecting pre-hospital resuscitation? What makes things complicated for us?
Environment?
Yeah, that's the biggest one, definitely. Our patients aren't on hospital beds, mostly. Our patients aren't in convenient places. They haven't collapsed in a nice warm ward. And what support have we got available in the pre-hospital setting usually?
EMS or CCP.
Yeah, what about a rung below? Is 3 people enough for this resus? What's the easiest way to get some more support? Just a backup request. Yeah. So we can get that backup request in, absolutely, and then we can think about senior support. 100%. So some of the tasks that need to happen, we need that team leader identified. I think whoever's walked in and isn't task focused is probably a good fit for that. If they're a paramedic, then ideal. Make sure high quality CPR is ongoing. That's always the most important part of ALS. Make sure that you're getting a team together if you haven't already. In this case, 3 people. We want to up those numbers a bit. A second crew is probably a good idea. Then we can start thinking about that airway problem, get ALS going, go through the history and the reversible causes. We've got environment up there as a factor affecting our care. More problems around leadership. Who's the leader going to be? What do they need to know? Do they know everything necessary already? And just make sure that that communication is there as well. Make sure everyone's safe, make sure that our actions are planned. So before we do anything big, like move the patient or chuck in a new airway device or something, you need to make sure that that's communicated, because if you're stuck down the throat with a laryngoscope and someone's charging the defib at the same time, that's a bit of a safety hazard. So there's our scenario again, and the things that we need to facilitate in the order that we need to do them. CPR comes first. Defibrillation, we've got an AED attached. Is that optimal? What have we got that might be better than an AED? Yeah, manual defibrillation with a life pack usually. Why is manual a bit better if it's in the right hands?
Fine VF.
Fine VF. AED is actually better at that than people are. But yes, looking at the rhythm and analysing it, fine VF is a whole can of worms. Sorry?
Do you defib shock VT?
Defibs do like to shock VT, yeah, so that's one advantage that manual's got, lets you pause and get that pulse check in. What's the key problem with AEDs though?
You have to have hands off while it's analysing.
Yeah. There's a big delay. Even the best AEDs are still slower than a good person with a manual defib. You've got that delay while it analyses, you've got the delay while it charges, because if, depending on the AED, it might not like you doing chest compressions while it charges. Manual defib, that's not an issue. You can get rhythm analysis done in less than 2 seconds and be ready to shock if you're really hot on it and you've got the right team around you. So once we've got our defib gone properly, let's look at this airway problem. It's very heavily soiled. There's nigel in situ, not ventilating effectively. What needs to go on here? Pardon? Someone said, I really can't hear you when you mumble.
ET.
That was like 3 things at once.
Chew.
It's the opposite problem. Chew! Someone said chew. Tube would be a good thing here, yeah. Obviously not always ideal. When you've got that team of 3, especially not. What's a simpler approach to a soiled airway?
Manual.
Take it out, clear it out. Yeah, take the eye gel out, clear out the airway, a bit of suction. Is an eye gel and a tube the only devices we've got available? We don't have LMAs in our bags anymore, but you might well have one knocking about. Yeah, you've got your oropharyngeal airways and your nasopharyngeal airways, the funny looking plastic tubes. It's not always the wrong thing to do to go down the airway ladder. In fact, quite often it's the right thing to do. Just be aware that there are complications of using basic airways for too long, mainly to do with BVM technique. But if you're waiting for someone to come along and help you out with that tube, then yeah, give it a go, see what happens. IV access or IO access, getting some drugs on board, not on everyone's priority list, especially not these days. Working through those H's and T's and getting some senior support involved. Most cardiac arrests, if they're recoverable, are going to need some senior support at some point. Maybe not in the arrest period, but ROSC certainly. We're going to be talking a lot more about that later. So here's a very unrealistic ALS team. What's unrealistic about it? The lovely amount of space and the fact that it's got 6 people who are all waiting patiently and doing things correctly. Yeah, this is kind of my idea of an optimal resus team. There's just one key thing missing. Yeah, there he is. Where do we want him to stand? How about over here?
No.
What's wrong with that? Can't see the defibrillator. Yeah. What's the really key thing about being able to see the defibrillator? See what's going on with the patient. Yeah, why not? Yeah. Okay, so if we put him over here, he's got a lovely view of the defibrillator if that airway assistant gets out of the way. What's the problem now? Oh, you're just moving that forward. Sorry? He can still see everyone, he can see the backs of their heads, but he can still see them.
They can't see it.
They can't see it. It's a barrier to communication. You want to optimise everything at resus, and communication is really one of the big things. So where I want this team leader is right over here. Lovely line of sight to that defib, right in everyone's eyes when it needs to be. What's the key thing about the team leader being able to see the defibrillator? What's this guy doing? Faffing with the airway. What's this guy doing? Also faffing, helping to faff. What's this guy doing? He's faffing away on the chest at 100 to 120 beats per minute. What's this guy doing? He's faffing about trying to get a cannula in the back of this person's little finger. This guy's the only one who's faff-free at the moment, and he's the only one who's going to be decisive enough in this lovely leadership position to make a quick, snap decision about what we're going to be doing with this rhythm. When it comes up to rhythm checking, what is it? Are we shocking it? Are we pulse checking it? If you have got a few people then form a line. I've done this before. I had 3 off-duty nurses approach us in an outdoor cardiac arrest. It was amazing. I had them lining up to get on the chest. It was wonderful. Then the CCP turned up and rolled it before any of them got on the chest. But it's unrealistic, I know, but it does occasionally present where you get to do something like that, which might make them feel a bit silly, but it's a really helpful thing to do. They know what they're doing and it helps them get in the zone. Cool. Peri-arrest. What does it actually mean to you? What do you guys think of as a peri-arrest? Please don't say news of 9, especially now that we've got news 2. But would you all agree with that? Imminent cardiorespiratory arrest, unless you correct it. Yeah, the patient who's sick, getting sicker, and is going to get mega sick. What about recognising them? Any thoughts? I have mentioned the news score. I have my own thoughts on that. Any features of peri-arrest patients? Want to call anything out? Cyanosis. Cyanosis? Cyanosis, yeah. Blue. Blue lips, blue ears, blue extremities, blue face, blue. Lovely. Any other peri-arrest features?
Pallor.
Pallor. What do we mean by pallor?
Very grey.
I'm just looking for who said that. Is you at the back? Yeah. Yeah, going grey, going ashen. That's a very ominous sign, absolutely. Other peri-arrest features that aren't skin colour?
Agonal breathing.
Agonal breathing. Is that a peri-arrest feature or an arrest feature? Probably arrest at that point. Yeah, that is a horrible, horrible thing to see. It is the last-ditch effort of the brain. Recently learned that it's a birth reflex, so it's good for babies, but it's a reflex you keep your entire life. It's completely useless after your first 30 minutes of existing. But yeah, that's what that is, apparently. Lovely thought. Here's a few features of some peri-arrest situations where we've got our airway problems, something in the airway that shouldn't be, or parts of the airway blocking other parts. Breathing problems, we've got respiratory failure, respiratory arrest. That is a form of arrest, obviously. It's just absolute loss of respiratory drive rather than cardiac output. What's going to happen if you don't treat the respiratory arrest? Cardiac arrest, yeah. Simple enough, isn't it? Circulation problems. These can be a bit funny because a lot of people have a myocardial infarction or tachycardia or bradycardia, but they're completely fine with it. Circulation is where peri-arrest tends to get a bit iffy. I've been called on grade 1 backups for query MIs where the patient had no adverse signs whatsoever, but yeah, the ECG tells the story. We still have this sort of quasi approach to that where we still semi-manage it as a peri-arrest. We might put a half-assed call into the local hospital and so on. But these guys do need to be monitored, obviously, because what is stable can go unstable in this kind of situation. Hypovolemia is not something that stays stable for long. What does it actually mean, hypovolemia? What's its literal meaning?
Low volume of blood.
Low volume of fluid. Yeah, fluid in the body. Fluid that should be in the body, out of the body. And then at the bottom, some cerebral sort of peri-arrest emergencies. These are all hallmark features of a massive sudden deterioration in the brain. Seizures are going to be the big one. That's the one that everyone gets to see one for these days. Raised intracranial pressure, where something is pushing on the brain that shouldn't normally be. And a significant GCS decrease. If there's a massive increase in the GCS and nothing else wrong with the patient's vital signs, that is almost certainly a neurological event going on. The problem being, they don't tend to get better, they tend to get worse. And as these get worse, this gets worse, this gets worse, and this gets worse. Anyone notice the order this is in? Primary survey, yeah? That's why we look at these things in the primary survey. That's why it's a good idea to have a quick glance at the pupils. That's why it's a good idea to open the airway before you check breathing, because these are all systems that can go very, very wrong. Immediately managing these, I love this picture. They're pushing the bed the wrong direction down the corridor and there's no one at the head of it where the handles are to push it. So they're perhaps walk into those doors probably, but yeah. Sorting out those airway problems. We want to get the obstruction out if it's a physical one. Don't do what someone at Greenwich did and yank out a tumour and pull out half the airway with it. But something that isn't attached to the airway, absolutely we want to try and pull it out. using our hands to move the airway around, get some adjuncts in. What kind of adjuncts have we got available? We talked about OPs, MPs, IGLs. Anything else? Tube again. There's one more. Third year's looking at you.
Needle.
Needle cric. We'll go back to that. Needle cric is kind of a form of front of neck access, but like I say, we'll go back to that. Sorting out breathing problems. Get some oxygen on. That's a good approach to most breathing problems. What's the obvious exception to the rule? COPD. Some COPD patients, oxygen is more harm than good. Not just COPD, some people with...
Neonates?
Sorry?
Neonate?
Neonates, we're talking about adults today, but yes, you are correct. Too much oxygen is bad for a neonate. Other respiratory problems include stuff like cystic fibrosis and certain poisoning. There's 2 poisonings that come to my mind where oxygen's a bad thing. Paraquat's one, what's the other one? Carbon monoxide, you need it, yeah. Bleomycin, everyone heard of that? It's a very strong antimicrobial agent and it works by attacking cell function, like most antibiotics do. But it's so good at its job that it will knock off your entire respiratory system if you get too much of it in your body. So yeah, oxygen for these guys, it's a very complicated process. It's to do with acidosis and movement of radicals, and I don't have the time to talk about it much, or the knowledge even. Sorry?
How would you diagnose it?
It's history, exposure to. So paraquat is an insecticide used in the industrial sector quite a lot for cleaning railway tracks and stuff. So someone severely short breath, low sats on a railway track who's been working on cleaning it, possibly paraquat at that situation.
And if you gave them oxygen and they start to deteriorate, once you take the oxygen back off, would they then improve or would they
So
stay?
I think the current recommendation is get the sats up to mid-80s, but don't let them go any higher than that, if that makes sense.
Okay.
They're probably not going to survive if they're that unwell anyway. You don't want to be faffing about and seeing with those guys, you want it to be the hospital's problem. Other breathing interventions, going to decompress tension. What's the easiest, quickest way to do that? Yeah, pop the chest with a needle. What's the least effective way to do that? Pop the chest with a needle. Ventilating patients, is it always appropriate to get the BVN out when they've stopped breathing? Always? Sorry?
Prepare for it to get out before.
Yeah. What about if they're still breathing but it's rubbish?
No, you need to do
Yeah, you can assist ventilations, absolutely. Has everyone got a happy technique for that if you've had a bit of practice on the road or in theatres or anything? What about ventilating neuro patients? Put your hand up if you've ever been with someone who's having a massive neuro event, you had to ventilate them. Did you do the slow squeeze thing? Bit of pressure when they take a breath, yeah? That's my technique. So if someone's still breathing and breathing poorly, I like to get a gradual squeeze on the bag, and then as soon as they take that breath, a bit more pressure, just a sharp intake, puff in a bit more oxygen. When we're looking after people's circulation, we're looking at getting bleeding under control, obvious one. Unfortunately, most medical bleeds are not easily controlled. We can give them some fluid and some medicine to help with C problems. Blood products, regrettably not very available in this country, especially pre-hospitally. But superior to fluid, do we think, for people who are hypovolemic? Blood or fluid? If you've got blood, yeah. If someone's there who's got some blood, then tap them on the shoulder. Pacing and cardioversion is using electricity to correct an arrhythmia. So if it's too slow, if it's a bradyarrhythmia, then a bit of pacing, which is very low voltage, regular shocks to create an artificial heart rate. Cardioversion is 1 to 3 high energy shocks to shut down a tachyarrhythmia, so heart that's going too fast. Very similar to defibrillation, just uses less energy. Disability, do what you can to restore the consciousness. Treat the seizure if there is a seizure, and if there's hypoglycemia or an overdose present, think about what you can do to manage those. Once you've done this basic management, you can look at definitive care. A lot of people love to grab patients and just fly to hospital with, whatever problem, and they don't think about doing any interventions first. At the very least, you need to work through your A to E and think about these basic things that you can do to sort out the most immediately life-threatening problems. Go on.
It sounds really stupid for me. Are we allowed to do a cardioversion?
So, I have cardioverted a patient with a HEMS doctor on the other side of the ambulance telling me exactly what to do.
So no, we don't.
Generally no. The reason for that is that conscious sedation is required, so they need to have some ketamine or midazolam or something so that they don't feel it.
Not your own.
Not drugs that are in the paramedic scope of practice in this area. It is possible that in the next few years you might see cardioversion for peri-arrest patients coming in. Pacing, probably not, but cardioversion, I think we might see that on the road more commonly. CCPs can provide both, so they've got access to the right medicines. And if you do your ALS course, you'll be taught how to pace and cardiovert, just they won't teach you the sedation part, unfortunately. So here's a medication that's helpful in the peri-arrest period. First one we're going to be looking at today is atropine. Has everyone heard of atropine? Should have done, I mentioned it earlier. Atropine is normally given at 500 micrograms. For some reason we have 600 in our ampules, so we just give that. It's a very strong anticholinergic medication, and if you give enough of it, it can restrict the activity of the vagus nerve and increases conduction between all your cardiac cells. So it gives them a higher affinity for reacting to one another and stops the body from artificially slowing the heart rate. Why might that be a good thing? If the patient's bradycardic, atropine might fix it. Some bradycardias will not respond to atropine. For example, a true complete AV block, there's no means for the atropine to affect the part of the heart that's actually experiencing the problem. So it might not be helpful for a lot of those. It is a relatively safe drug, but that doesn't mean just give it to any old Jimmy. And always try and treat the cause of the bradycardia first. So, you know, basic breathing assessment, get some oxygen on, look at assisting ventilations. Try and get their volume up if they're hypovolemic, and if they are hypothermic, treat the hypothermia 100%. Atropine given to a severely hypothermic patient could do them in, because if their circulation's gone peripherally and then it comes back later, they get little doses of atropine coming through. It can actually cause bradycardia. So we need to give it quickly, we need to flush it as quickly, because if it's given too slowly, unlike a lot of IV drugs, it's safer to give it quicker. If it's given too slowly, the little dose hits the heart before the big dose does, and you get the paradoxical bradycardia as it's described in all the guidelines. Anyone got any questions about atropine? It tends to be forgotten about a little bit these days, but it is an important drug to be aware of in your peri-arrest period, and it's absolutely a consideration for all your bradycardic patients if they're symptomatic. So, cardiac arrest. Moving on from our peri-arrest situations. Cardiac arrest. That's what I think cardiac arrest is. I think it's misleading to say it's when the heart stops, because we're increasingly seeing cardiac arrests due to trauma and hypovolemia where the heart's still moving, it just doesn't have any blood in it. So cardiac output is what goes when you have a cardiac arrest, for whatever reason. Some of these reasons are treatable. What are our reversible causes? What's our nice name for those? H's and T's. Hooray. So, third years, put your hands up again.
No.
Just left to right on the front row. What's your name, sorry? Starting with Chantel, can you tell me what lack of oxygen is on the H's? Ding ding. Well done. I've colour-coded all of these. It took me ages. Yeah, hypoxia. Lack of oxygen. Henry, what's a very low temperature for an H? Hypothermia, correct. What's your name?
Neve.
Neve. What are we looking at for an inadequate circulating blood or fluid volume? Correct. Oh, that one's a bit hard to see. Go on. This is probably one of the harder ones. Sorry.
Yeah, it's hypovolemia.
Yeah.
Metabolic.
Yeah. So this is a tricky one. The H in electrolyte imbalance stands for hypo and hypokalemia, because that is the most common electrolyte abnormality that leads to cardiac arrest. However, too much or too little of most of the cardiac electrolytes will cause cardiac arrest, hence the fact that the word metabolic gets tacked on there quite a lot. That's yellow because bananas. Charlotte, lead us in with the T's. What's a coronary or pulmonary embolism as a T?
Thrombus.
Thrombus, yeah, correct. Muzz? Toxins, lovely. Poisoning.
Tension.
Tension, what? Yeah. Or hemothorax, but usually pneumo. Yeah, absolutely. And last one, tamponade. What kind of tamponade? Cardiac tamponade, yeah. So hypoxia, simple enough. There is not as much oxygen in the blood as there should be. This causes cardiac arrest because the body needs oxygen to do anything, including pump the heart. So if it doesn't have enough, the heart will stop. Hypothermia, if the body gets extremely cold, metabolism slows down to the point that it will actually essentially stop happening. What's quite common with hypothermic arrest is that they go into an extremely slow PEA. We're talking heart rates of about 20. Do not mistake that for a rhythm compatible with life, but do monitor them for a little bit longer before you start CPR, just to make sure that you know exactly what rhythm they're in. Hypovolemia, not enough blood. Blood is what you need to stay warm, it's what you need to get oxygen around, it's what you need to move electrolytes in the body and so on. If there's not enough of that, you can't do anything. So yeah, cardiac arrest. Hyper or hypokalemia, this is a funny one. The electrolytes that keep the heart muscle moving, when there's too much of them, it can freak out a bit. That is the best way that I can think of explaining that. The problem isn't really so much the sheer volume of the potassium, it's the lack of calcium relative to the potassium. Because for cardiac cells to function normally, there needs to be an equivalent exchange between the two. If anyone's watched Full Metal Alchemist, you know exactly what I mean. Hypokalemia, the opposite applies. It's the imbalance between calcium and potassium. And at the other end of the spectrum, on the cardiac cycle, you've got your sodium and magnesium. I think there's another one that I can't remember at the exact moment.
So would they be your like crush injury patients?
Potentially. Dialysis patients are a massive candidate for this as well, because the nature of their disease is that their kidneys don't filter out enough waste. So that includes waste potassium. Potassium's normally the first one to go. So if they miss their dialysis or they're acutely unwell and it increases their circulating potassium, their kidneys aren't bringing it out of the body as fast as they should. Potassium goes up and up and up. Calcium imbalance against it causes the heart to go into all sorts of weird rhythms. We'll look at some of those later.
So is the majority of knowing that hypokalemia is by history?
Yes, yeah. Blood gas analysis will tell you, but that's not available pre-hospitally, unfortunately. Might be in the future. Some CCPs are campaigning for it on their vehicles, so we'll see. But yeah, it's going to be history-based. And the process in crush injuries, as was mentioned over here, is if someone's been crushed for a significant period of time and the cells beyond the point of crushing die out, they leak out loads of potassium into the tissue around them, the crush is removed, circulation returns to that area, it sucks all the potassium back into the main circulation. You've got a massive overload on the cardiac cells, and they can quite simply go into asystole like that. Pulmonary and coronary emboli, thrombus. That's a funny one really, because a thrombus is not that bad of a problem. An embolism is definitely a problem. What's the difference between the two?
One's moving, one isn't.
One has moved or is moving, yeah. A thrombus is a blood clot getting stuck somewhere, forming somewhere and sticking there. It becomes an embolus when it starts moving. So what does a coronary embolism manifest as?
MI.
Yeah, that's your MI, that's your heart attacks. Myocardial infarctions. Get stuck in a coronary blood vessel, blocks the flow to the muscle that would be supplied by that vessel. You get the chest pain, you get the cardiac failure, etc. Pulmonary embolism, what's going on there?
Lack of transport of oxygen.
Yeah, it is a PE. What was that, sorry?
No oxygen being transported.
Yeah, so it's the same process essentially. There's infarction happening on lung tissue rather than on the heart. The embolism is normally formed in one of the deep veins as a thrombus, as a DVT, generally in the leg, can be in the arm. And if it travels to the lungs and gets stuck in the wrong place, a really massive pulmonary embolism can be the primary cause of cardiac arrest. It can lead to cardiac arrest by other means, but rarely a massive PE might cause cardiac arrest. And the treatment for those is slightly different to your standard hypoxic arrests. Toxins, this is a huge topic. It depends on the specific toxin. Toxicology is its own discipline within medicine. Everyone always talks about Narcan like it treats everything in toxins. It might not actually treat much at all very usefully. But that is a consideration. If we think opioid toxicity is the primary cause of the cardiac arrest, we've got an antidote for that. We do have another antidote in our drugs bags at work. Does anyone know what that is?
Atropine.
Atropine is an antidote for CBRNE, that's absolutely correct. I was thinking of a different one though, thank you for saying that. It's actually glucagon. Does anyone know what glucagon is the antidote for?
digoxin?
I'm not aware of digoxin.
Is it for hypo?
It does treat hypoglycemia, but it's an antidote for a poisoning as well. Now, glucagon is a catecholamic hormone, much like adrenaline, and it functions in a similar way to adrenaline. But because of the slight differences between the two, glucagon works really nicely as an antidote for beta blocker overdose and calcium channel blocker overdose. That is not a listed indication in pre-hospital guidelines, primarily because it needs to be given at higher doses than we carry. But I have seen it used in hospital once, as we would, one shot IM for a beta blocker overdose. So maybe not something to jump straight in with if your patient's got a beta blocker overdose, but potentially something to discuss with top cover if you think it might be helpful. Tension pneumothorax, this is one of the more physiologically interesting causes of cardiac arrest because it's something you can see, something you can almost get your hands on. What is a pneumothorax? It says it there. A gas in the pleural space that shouldn't be there. Yeah, there shouldn't be much gas in the pleural space ever. If too much gets in there, it starts to compress the lung. What's the difference between a pneumothorax and a tension pneumothorax? How do we decide it's tensioning?
It can't go back.
Yeah, there's no room left. It's gotten to the point where it's putting massive pressure on the thorax. And this causes cardiac arrest through obstructive shock. It compresses the heart and it physically hasn't got the space to move. If you are able to successfully decompress it, in theory, you should get a very quick ROSC if you've done it quickly enough. Tamponade, similar process. I can do something with my hands to demonstrate this one though, which is quite fun. So the heart is surrounded by this thin protective layer called the pericardial sac. And that is the bit that we're worried about with tamponade. If that fills with blood or fluid from fusion, then it can start to compress the heart in a similar way to a pneumothorax. So you've got your heart happily pumping away, and then this pericardial sac starts to fill with fluid. I'm squeezing my hand quite hard now, and it's harder for me to squeeze it. If that keeps squeezing, I just get nothing. Can't move my hand at all. Same process happens to a heart in tamponade. It's being squeezed, it doesn't have the space to contract and refill and so on. So that's a little rundown of the H's and T's.
What can we do
What's going on
to
here?
help tamponade?
You can get HEMS there.
So that's all we can do.
I'm
We can
afraid
get-
so.
But that's like a general thing for like for us to try and get a CCB anyway.
Specifically HEMS for a cardiac tamponade if you suspect one.
Okay.
Because
There's
So
nothing
then why
just
do we not call them for every cardiac arrest?
Yeah.
Because tamponade is very rare. Causing cardiac arrest is from
But if
tamponade
we
is
can't
quite
rule
rare.
that out as paramedics, how do
So I'm going to talk about presenting features of different reversible causes in a bit, but you have raised a really good question. Quite simply, the usual answer is we assume tamponade is not there unless there's a history suggesting it is. Go on, mate.
Can you pericardial thumb?
Precordial thump. Pericardial thump, you need to cut the chest open for that. A precordial thump is for treating VF. It doesn't treat tamponade. The two treatments out there for pericardial tamponade are pericardiocentesis, which is when a large needle goes through the chest wall, which is largely thought to be useless, and thoracotomy, which is known to be very, very helpful, but is extremely invasive and requires a HEMS crew to do it. So let's look at this scenario. A bit more wordy, I'm afraid, but I have cut it down. It was more boring than this before. Just read through this little paragraph and this set of odds and everything below it, and think about what reversible causes this patient might experience that could lead to cardiac arrest. Mara, what's the problem? What's wrong with this patient?
She's got a respiratory problem.
What kind of respiratory problem?
Well, she's got the asthma.
Yeah.
Has she? Or what?
What's the most likely explanation of her symptoms? You've already said it.
Have I?
Yeah.
Were you earwigging?
No, just now when you said it in front of me. Asthma, yeah. Yeah, she's having a severe asthma attack. Yeah, you don't need to overthink these things. When we're resuscitating people, we keep it simple. We go with the likely cause. Asthma, yeah, that is the likely problem here. So what reversible causes could be affecting this person now and could lead to a cardiac arrest? Yeah, she is hypoxic, isn't she? She's massively hypoxic. People with asthma don't go that low on their SATs unless they're really unwell. And they don't stay that low with high flow oxygen on unless they're really unwell. So yeah, she's definitely hypoxic. That is a very, very feasible cause of her potential cardiac arrest. What else?
Tension pneumothorax.
Tension pneumothorax. Severe life-threatening asthma does create a risk of tension pneumothorax. So that is another potential reversible cause. There's one more that comes to mind that should be a consideration.
Infection?
Sorry?
Infection?
Who said that? Sorry. Oh, hello, Casper. So she does have an infection, probably, yes, because she's got that productive cough and that little fever. Is she septic? I don't think. Clinically, I don't think she's septic. She does meet some sepsis criteria. What is the more likely explanation of those low SATs and that high rest rate, though? The asthma attack. I'd be surprised if this woman's septic. It is a consideration, though. What about the slightly more respiratory sounding cause of cardiac arrest? Yeah, PE. That should be a consideration. Febrile, young lady with shortness of breath. Those are some features of PE. She's also tachycardic. Again, more likely to be explained by her asthma. Just going back to sepsis quickly, what kind of cardiac arrest does that cause? Hypovolemia. Where's the fluid gone? People with sepsis, we monitor their urine output because we want to see it go up. We want fluid coming out of their body. So where's the fluid gone? Sorry? Interstitial. Yeah, it's been redistributed. It is a form of shock, but it's not hypovolemic. It is a distributive shock. It is, however, reversible. So it comes under the hypovolemia banner for the purposes of cardiac arrest. It's just an interesting sort of little flaw in the paradigm there. So we've got hypoxia, tension pneumothorax, and thrombus as potential T's here. Oh, sorry, ACAmb here. And then we've also mentioned sepsis as a little differential in the back of the head, 100%. So, because we know exactly what we're doing, we get some oxygen-driven salbutamol on board. Take some more obs. Read through the rest of that, and then have a look at those obs at the bottom and the question what we should do next. What's your name, mate? You with the red t-shirt, sorry.
Stephen.
Stephen. Because I think you know the answer, I'm going to ask you to keep quiet. Just for this one, though. Okay, who exhaled the answer just now?
Someone did.
Do you want to say it a bit louder? It was correct.
Tension pneumothorax.
Yeah, she's having a tension pneumothorax. So she was probably having a pneumothorax before, and it's now gotten to the point where it's tensioning. How do we know it's tensioned? Look at that blood pressure, and then that blood pressure. Her cardiac output has just plummeted. She's lost her radial pulses because her cardiac output has plummeted. She's dropped her GCS because her cardiac output is in her boots at the moment. The amount of blood going to her brain is severely impaired by the pressure on her heart at the moment. So what are we going to do about this? What do we do immediately? Sorry? Call someone. Mum? My mum's a nurse actually, so she might know what to do. Okay, so you're going to call someone. What's everyone else going to do? Do you want to change your answer? That's all right. If you're first year, then that's a perfectly acceptable answer. Yeah. Pop a needle in. Cool. So needle decompression. Lovely. We do that, we get hiss.
Sorry, what causes pneumothorax without trauma?
Without trauma, so it can be to do with pressure building up in the lower airways. So with asthma, we've got air trapping going on. And if we start to rupture alveoli and so on, we get gas escaping into the wrong places. So that's one process by which non-traumatic pneumothorax can happen. It's quite common with lower respiratory problems, especially asthma, but probably only because asthma is so common. So we get our audible hiss, we finish our nebulizer, we take it off, and we can see that the amount of effort that she's putting into her breaths has dropped. What are we going to do? Reassess. Yeah, lovely. I was expecting at least one wrong answer. Perfect. Great. She's apneic now, and she's barely got a carotid pulse. What's about to happen? She's about to... She is peri-arrest now, yes. So what's about to happen? Yeah, she's going into cardiac arrest. And so what should you do? Pads on, what else? Call for backup, what else? Yeah, get some vents going, absolutely. Prepare for resuscitation. So think about your environment, get her on the floor, get her flat, get her head raised with a little pillow or something so you get a good airway, get pads on, make sure that you've got the right equipment in the room and get that backup coming, absolutely. Lovely. We'll go back to her in a bit. So if we're providing ALS during cardiac arrest, and I'm going to talk about ROSC as well in a moment, we're using our Dr. ABCDE approach, reassessing after we perform major interventions. But most importantly, we need to make sure that our BLS is of the highest quality. We need to make sure that we're recognising and shocking VF and pulseless VT. And this means that we need to be planning our actions around these things, make sure that we're coming up to rhythm checks. Everyone knows that, everyone knows their job in the rhythm check. Right, yeah, rhythm check time. So, come off the chest check, see the monitor, okay, that looks like VF. Yeah, you think that's VF? Okay, charge the monitor, get back on the chest. Cool. Okay, it's charged. Right, you use the defib, right, everyone, yeah, stand clear. Counts it in. We get the shock on, cool, and back on the chest. Okay guys, we're about 30 seconds away from our 2-minute mark. So what we're going to do is I'm going to ask you to stay on the chest for the time being. You can disconnect your airway now and just put the BVM aside so we don't have any oxygen. If we get the defib charged and be prepared to shock or dump the charge, and if a couple of us can get fingers on pulse points as well, then we're prepared for anything. So you on the chest, just listen to my voice, alright, and follow my instructions. Okay, so off the chest, can we feel a pulse? Can we see on the screen? I can see VT, is it pulsed? No. Okay, back on the chest, is everyone prepared to shock? Okay, staying clear and shocking. So you can see how preparing for actions, even with that little thought experiment, allows you to reduce time off the chest drastically. Think about having fingers on pulse points. Think about charging the defib, even if you're not sure if you're going to shock or not, because you can dump the charge. Does everyone know how to do that? So you know on the life packs anyway, I don't know about other monitors, but on the life pack you've got your speed dial thing. If you press it in as a button, when it's ready to shock, it'll drop the charge. So you can have it ready to go before any rhythm check and absolutely minimise your time off the chest there. Once we've got our BLS underway and going nicely, we're going to manage airway and breathing, recognise the need to escalate our airway and recognise the need to escalate our practitioner. Get our access in, give the appropriate medicines, which we're going to talk about in a moment. Get all the observations we can. There's two really key ones that often go by the wayside in cardiac arrest. What are they?
Yeah.
Blood sugar? Temperature, yeah. Blood pressure in cardiac arrest is negligible. You might be able to record blood pressure, but it's not going to be helpful. Because if they are in cardiac arrest, you're feeling the pressure of the CPR, not of the heart. So once we've done all these things, we can then go through our H's and T's together. So, here's your task list, and here's some methods that I've come up with for getting things done. Keeping control of the scene. Keep that risk assessment going, make sure everyone's safe. Who's the team leader, and are they right for the job? Is the teamwork going nicely? Are we communicating properly? Planning and verbalising like we should, like I did with that little demonstration a moment ago? Have we got high quality CPR going? Shout out some features of high quality CPR. Correct depth, correct rate,
Recoil.
and correct recoil. Absolutely, those are the three main ones. We also want to be checking at least every 2 minutes that we've got a new CPR provider lined up. If you've got Fat Bob the PCSO on the chest for 30 seconds and he looks like he's about to die, Should you give him another minute and 30 seconds?
No.
No, probably not. His CPR is not going to be very good. Give him a rest, yeah. You've already got one on the go, you don't need two. Yeah. Why might a metronome be helpful during cardiac arrest?
Keep the rate going.
Yeah. There's a nice way to approach making sure people use the metronome as well. Some people don't like being told you're too fast, you're too slow. To be honest, it's not a nice thing to hear. You're not doing this right. You can approach it by saying, just make sure we're matching the metronome with the CPR. Hear the metronome? Yeah, just make sure we're going at that speed. And interruptions, already talked about going around rhythm checks and shocks and so on. Is there another time that we should interrupt chest compressions? Sorry? So that would be stopping them, but if we're stopping and starting, any other situations?
Intubation.
Would we want to stop chest compressions during a tube?
If you're listening to the chest.
So I would tend to listen during the scheduled 32 rather than stop just to ventilate. Unless you think the tube's in the wrong place, then it might be appropriate to just stop, have a few quick listens just to be sure.
Yeah.
Because pulling that tube out is a big decision. But during the process of intubation, that tends not to be the way anymore. Go on, sure.
Where would it stand if you've got vision of the cords, but every single time you close, your bougie's just going like that?
Your bougie's wobbling.
Compression.
Have you got a mouse jumping on the end or something?
It's just really effective compressions which make your bougie slip every time.
You could ask someone to hold the head.
But then, like, you're changing your position, I've already got a view, like, I'm so close and yet.
Well, if it's bouncing that much, you haven't really got much of a view, have you? Is it safe to go into an airway that's moving all over the place?
The airway wasn't moving, it was
maybe
the
not.
bougie.
Okay. The bougie's moving. Independently of the person. I think you've got a haunted bougie. Just talk me through what was happening there again.
So okay, it was like a grade 2, 3 view,
Yep.
but with every single compression, it just kept slipping under.
So when they compress, presumably the body's moving a bit, it's pushing the bougie out of the way of the larynx. Is that what you're saying?
Yeah.
Right. How close were you holding it to the tip? Because the further back you are, the less stable it's going to be. That's one thing.
Well, like my hand was in their mouth.
No.
But
But yeah, don't hold it too far back. It's like writing with a pencil. It's easier if you hold it to the end. Another thing you can do is if you position it between your fingers like this, and then you get a bit of a squeeze on,
yeah.
the bougie conforms to the squeeze that you're doing, and it pokes upwards.
Okay.
So that gives it a little bit of traction, pointing in the right direction. If you're really brave, you can look up Scott Hardy on Twitter and look at his weird bougie tricks that he does. But I wouldn't recommend using them on the road unless you're prepared to justify yourself to the medical director. Although he might be a part of that panel because he does work for SECAmb. Yeah, interesting question. I can't say I've had a bouncy bougie myself like that, but yeah,
I've not have been like, right, just like leave out like one compression, like 1 second for in.
If you think it's that much of an issue that you need to intubate, which in this situation with a grade 3 airway, it sounds like it might have been because difficult airways don't tend to respond well to
there
eye
was
gels.
blood, vomit.
So okay, so that does sound like a good candidate for intubation, but think very carefully about whether it's really necessary in that kind of situation, because the risk of an esophageal intubation going unrecognised is, well, it's death, isn't it? Whereas the risk of a bit of pulmonary edema from using an eye gel for a few minutes extra is not guaranteed death. Go on, mate.
It's a bit of a random question,
Mhm.
but with regards to CPR and ALS, when last on placement, I was told that it's not 30 to 2 anymore. It's continuously.
When were you last on placement?
April.
Was it April, May?
Yeah.
So
But I know they keep changing it.
Yeah.
So I'm saying, where do we stand in knowing and finding and stuff like that?
So what ambulance trusts are quite good at is pretending that paramedics aren't autonomous healthcare professionals capable of making their own decisions. You do have to be able to justify your decisions, but if you feel you've got a good
Because it
tube,
was like such miscommunication. Some people went to do 32, some people were just like ventilating.
so if you feel you've got a good tube or a good eye
It
gel
was a
even,
tube.
and you've got someone on the airway who's capable of doing safe 1 every 6, then that might be the better thing to do because it reduces the
How do you judge
interruption.
that?
How do you
Because they
judge
just said a
that?
fat person should be 30 to 2 and a normal person. That's what it said to
Okay.
me. So I just want to know, like, genuinely, where do we stand?
To answer the question from the SECAmb perspective, my current understanding is that we are going back to 1 every 6.
One
where-
every 6 continuous compressions.
Whereas before,
It was
we went to 30 to 2 again, and now we're going back to 1 every 6. You can program the metronome on the life pack to give you ventilation
Yeah.
every 6 seconds,
So
so
at
make
what
sure you do
point
that.
would you decide as a paramedic that 30 to 2 would be more effective for the patient?
If I felt whoever was on the airway wasn't able to do 1 every 6.
That's it.
Yeah.
So it doesn't matter about body size, what their body's doing.
I
it's
would
just-
not make that judgment based on the patient. I would make it judged on the arrest, so the situation in front of me, what's going on there.
Yeah.
Or if
Based
the
on
environment's
people
too
who
chaotic,
take
it doesn't have to be an issue of incompetence. It could be a difficult environment or something. We're fixating on intubation, which I know we love doing as paramedics, but let's go back to ALS. So looking at rhythm monitoring and defibrillation, make sure our pads are in the right place. What is the right place for paddles? For defib paddles? Where are they going? Anterolateral, yeah? What if there's a big old pacemaker here? Are we aware that we should try and avoid those if possible? We can go outward a little bit. In theory, a biphasic defibrillator should work if the pads are here. Because all that needs to happen is the 2 electrical impulses both need to pass through the heart. So as long as the vector between the 2 includes the heart, or most of it, then you should get effective defibrillation. We do need to make sure that there's nothing between them. So to answer a question I got from a nurse on an ILS last week, yes, you do need to cut the clothes off. And it may be an idea to shave some of that chest hair off if there's loads of that as well.
If it's got to go through, would
Sorry?
it not just like if it's got to go through, wouldn't it just be easier to go one on front, one on back?
So that would involve bringing the patient up onto their side, which would be quite a difficult thing to do during CPR, which is why this placement is recommended for emergencies, which cardiac arrest certainly is. The other advantage of this is it's easy to put on around active chest compressions, so you don't need to pause CPR to put your defib pads on if you're going anterolateral. Just follow the diagram on the pads. That's the nice easy answer. If we're having a really, really hard time getting our, if it's a fine VF arrest like we mentioned earlier, if we're having a really hard time interpreting the rhythm due to bandwidth problems, or there's a big airway issue that's taken up a lot of our attention, we can consider going back into AED mode, or just turning on the VT alarm, which will allow you to, or will advise you on what it thinks is and isn't VF. Obviously not as good as a competent rhythm interpreter, but sometimes bandwidth means that no one in the room can interpret it correctly. Airway management, make sure the person with the appropriate skills is on the airway. I don't know if you guys are aware, but iGel is moving into everyone's scope of practice in SECAmb, so all of your ECSWs should be able to do it. I would still recommend, if someone's available, get someone with a bit of experience and a bit more in-depth knowledge about airways on there, especially as they can't do laryngoscopy, but they can drop that iGel in if they really need to. Have the right equipment available. Everyone know about doing the kit dump? I hate that phrase, but yeah, laying the equipment out in a sensible manner. And make sure there's an assistant for intubation. I've done 1 tube without an assistant. I would not recommend it. The only reason I didn't have an assistant was because of the environment we were in. I wouldn't recommend being in that environment. Oh no, I tell a lie, I've done 2. The other one was cardiac arrest in a bathroom where there was no space because to my left was a wall and to my right was a toilet. So I laid all my equipment out on the toilet seat. Yeah, an assistant makes your life a lot easier, especially bougie intubation. Using a bougie by yourself, don't even try it. It's just not worth it. Ventilation, make sure you've got oxygen attached to the BVM. It will work without oxygen, but we want to make sure that we're getting some into the patient as much as possible. The delivery system for us is going to be oxygen tubing. Ventilators are coming off the trucks, but you might see them pulled out at arrests from OTL and CCP vehicles. ETCO2 monitoring needs to be applied. Does it matter if that's colorimetric or waveform?
Yes.
Yeah? Why?
So you can see shark finning.
Shark finning, yeah. What's the other issue?
Dark.
Sorry?
It's dark. You can't see.
If it's dark, yeah, you can't see colorimetric capnography. Well, it's not capnography because it doesn't create a graph, it's capnometry. You don't get accurate capnometry with a colour one either. It just tells you if CO2 is moving or not. Waveform capnography gives you instant feedback on if you've lost the tube, if it's slipped out or something, and it'll also tell you if you have an impending ROSC, because CO2 should rise. Appropriate rate as well, we've mentioned 30 to 2, 1 every 6. In ROSC Care, 1 every 6 is your go-to. We'll talk a little bit more about that in a bit. Circulatory access, have the right kit available for the job. I've heard a rumour that the 2020 resus guidelines are going to go with IO access first, if it's available, because it's that much quicker, and intra-arrest, the peripheral shutdown doesn't matter. That's just a rumour. I don't know if that's in the guidelines yet, but it's what a lot of people are doing out on the road, because it is that much quicker and easier. Adrenaline and amiodarone go into our non-traumatic arrests, and amiodarone goes to our shockable arrests only. We need to think about other drugs, and I'll be talking about some of those. And fluid is indicated for some arrests, but I have some feelings about fluid that I will make clear later. Work through your reversible causes, that's the phrase everyone uses, and measure your blood sugar and your temperature. It's quite a task list. This is why you need a team, this is why you need a team leader, this is why you need a fair bit of kit and bandwidth. Before we go on, does anyone want to raise any issues they've got with that? Have I missed anything? No? Cool, just let Casper take his picture. So, next medication, this is going to be adrenaline. Adrenaline, 1 in 10. This is a milligram of the drug in 10 mils of fluid. Same dose as you get for your little ampules of it, but it's ready to go for a cardiac arrest. It's diluted so that it doesn't completely demolish all the blood vessels it's going through, but it still needs to be followed with a big flush. Why do we actually give adrenaline? That is a question lots of people are asking, and they're finding some mixed answers to. Does it do more harm or good? Currently, we're not too sure. However, it's still in the guidelines, it's still in the drugs bags, and it does help some arrests. So we're still giving it. What it actually does is it stimulates the agonist effects of alpha and beta receptors, which are found all over the cardiovascular system, and some on the respiratory as well. The effect of this is that it causes peripheral vasoconstriction, it squeezes the blood vessels in the peripheries, and central vasodilation, because the receptors are distributed differently around the body. There's more alpha-2 on the heart, I believe, and more alpha-1 everywhere else in the body. So this means that blood goes from the peripheries into the middle. In theory, this increases perfusion to the heart. In theory. It does also increase blood pressure because the constriction squeezes the blood vessels. Obviously, there's less space, there's more pressure. Chronotropy refers to the heart rate. So if there is a heart rate intrinsically, it should try and increase that as well. A side effect is it releases the glycogen stored in skeletal muscle and smooth muscle in some places as well, I believe. And what that does is it brings up the blood sugar. So side effects of adrenaline is that you can get blood sugar increases. You give adrenaline in your cardiac arrest patients immediately if it's PEA or asystole, and after 3 shocks if it's VFVT. So important difference there. So as soon as you've got your access for your non-shockable arrests, adrenaline's going in. If it's shockable, you need to give 3 shocks first. Doesn't matter if they're consecutive or not, but 3 shocks. After the first dose, the following doses are every 3 to 5 minutes. What's the best way to count 3 to 5 minutes intra-arrest? 2 cycles of 2-minute CPR. Every other cycle. So at the end of every other cycle, you're going to give the following doses. We do want to give this drug quickly, but we don't want to force it, because forcing things into a cannula can go horribly wrong. But do give it quickly and follow it with a large flush, because similar to atropine, if you give small bits at a time, intra-arrest in particular, you can have some problems with the blood vessel that you're giving it into. Amiodarone, 300 milligrams in a 10 ml syringe. These are same size syringes as adrenaline, but they come packaged in a different colour box. Has everyone seen the boxes that they come in, arrest drugs? So it's a purple plastic box for adrenaline and an orange one for amiodarone. Amiodarone is an antiarrhythmic agent which increases the time that should take place between each movement of the heart, each depolarization of the heart. in theory, this treats VT and VF by slowing down the amount of activity that the heart can feasibly do in a given period of time. We give 300 milligrams after the third shock and 150 after the fifth. So that's 10 mils for 300, 5 mils from a different syringe because there's only 10 in each, 5 mils from a different syringe after the fifth shock. It can actually lead to a form of VT called torsades, which I've got an example of here. So if you see this form of VT where the amplitude is changing up and down, it might be best avoided. It can't really get much worse than that, but if you do successfully treat this and they've got amiodarone on board, it can cause it again. So consider withholding it in the event of torsades being present. It doesn't actually say that in the jail calc guidelines, it just says it's a possible side effect. So I would want to discuss that with top cover. I think I'd just say to them, look, this guy's in torsades. I don't think I should give amiodarone. I'd be surprised if they said, no, give it. So similar to adrenaline, just need to make sure it's going into a big access. So if the best cannula you've got is pink, that's not going to do it for this because this is an incredibly toxic drug. It's extremely damaging to blood vessels and you risk losing your access if you give it into a small vein. So IO or a big cannula, green or bigger, ideally further up the arm or the leg. Can't really go too far up the leg, but yeah, somewhere up here with a big cannula is ideal for amiodarone. Again, follow it with a big flush to flush it out of that blood vessel so that it's doing minimal damage to it. So reversible
I've got a
causes.
question about the adrenaline.
Mhm.
So we went to a guy who was in cardiac arrest
Yep.
and we was given the adrenaline
Yep.
and he was in PEA. But the clinician, I think it was like, I think it was just a PE or someone,
Yep.
was saying about how he thought that the adrenaline was creating the PEA. And after consulting with whoever it was, this was in first year, so I was kind of a, and they were saying that basically to hold off with the adrenaline
And see if they get pulse, yeah.
and they
So-
did. So it's
So
could you do
think
that
of,
as just a paramedic, or would you have to?
I would discuss that with critical care because
Yeah.
that's a deviation from established guidelines. However, it is the right thing to
Because
do
they've given
sometimes.
a lot of it, and they were like calling more backup
Yeah.
for more of it, and it was kind of
See, at that point, it's getting a bit silly.
yeah.
I would consider that definitely. Think of the heart in cardiac arrest as a drowning person. Some people are better at swimming than others, but we're all at risk of drowning if we get into too deep of water. If you throw adrenaline to someone, it's like throwing them a grab line. And if they've got the strength to pull themselves back on the boat with it, then they'll do it. You can only throw someone so many grab lines, and if they just haven't got the strength, then they're going to drown.
Yeah.
If the
I
heart
think it was
doesn't,
getting to a point where it was just getting
Yeah.
ridiculous, and everyone was kind of going like.
if the heart's just clinging onto that adrenaline, and it's not making any effort to pick up the pace and get itself out of that situation, adrenaline is essentially a life support machine that we have to make the decision to switch off sometimes.
Yeah.
And if the heart doesn't want to take up the slack, so be it, unfortunately. So, identifying these reversible causes. Hypoxia. Who here has been to a cardiac arrest patient who wasn't hypoxic? Good. It's present in every cardiac arrest because the person's probably not breathing, and if they are, it's not going to be effective. So we're going to assume it's there, and we are going to treat it, but CPR and defibrillation is still more important. The exception to the rule is your traumatic arrests if you're using your HOT algorithm. Not going into that today, but if you are aware of what that is, you're going to treat your hypoxia, your hypovolemia, and your tension tamponade first before you do your CPR and defib. All medical cardiac arrests, these are your priorities. And then we treat the hypoxia next. We treat it with A&B management, surprise, surprise. Get some oxygen in. Hypovolemia, we recognise this because sometimes it's obvious, there's blood everywhere, or there is a history suggesting, so those would be your septic arrests, and people who have had really severe diarrhoea for like 14 days or something like that could feasibly go into cardiac arrest. We're going to treat it with some volume, normal saline or Hartmann solution if saline is not available. Blood is supreme for your hypovolemic arrests. Query whether it's good for septic arrests or not. There's a bit of interesting research out there at the moment. But blood definitely for your blood loss patients. That includes your medical hemorrhages, so your GI bleeds, your PPHs, where people have lost blood during childbirth and so on. The electrolyte problems that we talked about earlier, it's history normally. We're not going to have the facilities to test for it. We can measure their blood sugar, and that tends to fall under this H. But hypoglycemia as a primary cause of cardiac arrest is actually extremely unusual. The heart is the last thing to go. The body does everything it can to keep the heart going. If it's got any sugar going whatsoever, it's using it to fuel the heart. What will happen is that they go hypo, they go unconscious, they go hypoxic, they arrest. They might be hypoglycemic, but correcting that hypoglycemia isn't necessarily going to correct the arrest if we're not also correcting the hypoxia that's come from that hypo. So just keep that in mind. Hypoglycemia can cause arrests, but not always directly. Treatment for electrolyte abnormalities is calcium chloride if we suspect hypocalcemia or hyperkalemia, but otherwise we're just going to need to transport these guys. CCPs carry calcium chloride, HEMS carry calcium chloride. I would like to see calcium chloride on all ambulances, but it's going to be a pain in the backside trying to make that happen. Hypothermia, cold, really cold. If you've got a cardiac arrest patient 34 degrees, they're probably not in cardiac arrest because of their temperature. If it's like 25, then yeah, I'd be starting to think maybe a primary cause. The key thing here is usually going to be the environment. This is going to be your rough sleeper or your adventurous person who's gone a bit too far in the wrong direction. There is a lovely resource that I've just remembered that I didn't put in this PowerPoint that I would encourage you to write down. If you just look up the Winnipeg cold card sometime later. Winnipeg, WINNIPEG, cold card. That is a card designed for rescuers to tell you how to examine a hypothermic patient. It's a really good resource. It's probably copyrighted, so I don't think I could have put it in here anyway, but yeah, really, really good resource. Treatment for hypothermia is going to be to get them to a warm location and target a normal temperature. We don't want to overcook them. But even if you've got HEMS and CCP there, they're going to want this patient transported because warming someone up is much, much easier in a hospital than out of it. Thrombus as a cause of cardiac arrest. This is going to be suggestive history usually, although collapsed middle-aged person in VF, probably an MI, probably thrombo as a cause. Most common cause of cardiac arrest versus PE, which is probably one of the least. But yeah, MI causes the most arrests and it tends to present in VF. So don't worry too much about getting into your H's and T's if you're treating VF because you've got your eyes on the monitor and everything. But keep in mind that there can be multiple causes contributing to an arrest. So even if you suspect MI is the primary cause, which it normally will be, just go through your H's and T's still in case there's something else going on. Treatment for these is obviously defibrillation, but they do need to have some PPCI if they're having an MI. This is the procedure done in certain hospitals where they're going through an artery, either in the leg or in the arm, to stent the coronary vessel, which is blocked. This makes it wider, lets blood in. Thrombolysis can be done in anticipation of PPCI by HEMS and CCPs. So this is using drugs to break down the clot extremely aggressively. There are a lot of medicines involved there. They're all very expensive and can be quite dangerous as well, which is why that's not a typical ambulance intervention. Toxins. If someone's overdosed on illicit drugs or prescription drugs, paraphernalia and packaging can be a good indicator. They might have signs that they've been injecting themselves chronically. Risk factors. So thinking about the person's socioeconomic status, where you found them, think about incidence and prevalence of drug overdose among different population groups. For example, homeless people, very high chance, very high levels rather of drug abuse compared to the general population. And just that history leading up to as well. There's one sign of opioid overdose that is quite a famous one. Any ideas? Yeah, the pinpoint pupils. How many people have gone to elderly patients who probably aren't on heroin but have got pinpoint pupils? If we've got an antidote, think about giving it. I say think because you'll see why. And transport them to hospital early. So once you've got a secure airway, you've got ALS going, these guys need their tox profiles done, they need specialist support, they need toxicology on the phone. This needs to be done in hospital. Tamponade, blunt or penetrating thoracic trauma. This is the suggestive history of cardiac tamponade. The only other fairly specific sign of cardiac tamponade is massive jugular venous distension. Very big blood vessels coming out from the side of the neck. Has anyone seen that picture that's been going around Facebook lately of the lady with JVD? Yeah. She had a cardiac tamponade. So yeah, we're going to suspect this in our traumatic cardiac arrests involving the chest or involving major falls from height and so on, where there is a possibility that there's been a big impact to the heart or penetrating trauma sort of anywhere around here. Treatment for this is a thoracotomy, which I'll tell you a little bit more about later. HEMS can provide the quickest thoracotomy almost always. If you're on the doorstep of a hospital that knows how to do it, that you know can do a thoracotomy and they can do it the minute you walk in, get them in there. Otherwise, HEMS is probably actually going to be quicker because they will run on these jobs like there's no tomorrow.
Which ones in Kent can do that?
Which hospitals?
Will the Harvey be annoyed if you bring them on?
So, I would trust the Harvey to do it. I would not trust certain other hospitals. In emergency medicine guidelines, it clearly states that everyone who's at least at registrar level in EM should be capable of doing a thoracotomy. That doesn't mean that everyone is, and it doesn't mean that the hospital's got the tray ready so they can open it and they've got all the kit ready inside it. What a lot of hospitals do if you tell them they need a thoracotomy is they're like, all right, I'll bleed cardiac surgeons. By the time they pick up the phone, the patient's dead. It's a good idea to grab one of the consultants in every A&E you visit and just out of curiosity, mate, we were talking about this the other day, do you do thoracotomy here? Could you do a clamshell thoracotomy if we brought someone in? And see what their answer to the question is. They probably don't know a lot of the time. But it is something that every hospital should be able to provide. Unfortunately, not every A&E can.
I have been told if you're near a certain hospital, park up at the green around the corner and call HEMS.
Yeah, I wouldn't be surprised if we're thinking of the same hospital.
Is it Medway?
No, I'm just wondering if we're thinking of the same hospital where no one knew where the catastrophic hemorrhage kits were, and they were locked in a major incident cupboard to which no one had the key. Because we're not a trauma centre. Tension pneumothorax. Same signs and symptoms as tamponade. For traumatic issues, but we've also talked about respiratory problems causing cardiac tamponade. Spontaneous pneumothorax rarely occurs in generally tall, otherwise healthy adult males after exertion. Signs and symptoms, they will have JVD if it's really tensioning, but they will also have the silent chest on one or both sides. Brick bag, which is when you're squeezing your BVM and you're just not getting the right pressure, you can feel something's very wrong with it. Asymmetrical chest movement. Maybe some tracheal deviation if it's tensioning for a while, the trachea starts to shift with the mediastinum. What about hyperresonance? Everyone heard of that? Who's done their chest exams? Tapping on the chest, yeah? Who the hell is going to be tapping on the chest looking for what does hyperresonance sound like? So these guys need a needle in the chest. If that doesn't work, they need a thoracostomy, which is cut down in the side of the chest. And HEMS can provide thoracostomy to anyone. CCPs can do it intra-arrest only, and hospitals can provide it hopefully to anyone if they've got an appropriate ED. And that's not specific to trauma centres because pneumothorax happens in medical situations as well. There should be a thoracostomy tray in every resus, I hope. Sorry, did someone I saw someone have a phone out, did they want to take a picture of that?
Thank you.
Yeah. If you want me to send you the slides afterwards, send me an email, it's fine. So a few more medications for managing irreversible causes. Normal saline goes by many names. This is the chemical equation for sodium chloride, the molecule. Sodium chloride is an isotonic fluid. That means it doesn't affect the osmolarity of the bloodstream. It shouldn't. So it doesn't shift fluid in and out of cells. It just increases the amount of fluid in the bloodstream. This is good for certain hypovolemias because it allows the heart to pump with a bit more vigour. It increases that preload and gets a bit more out with every heartbeat. We tend to use it for hypovolemia and distributive shock, and we use it more cautiously for dehydration. Generally not a pre-hospital measure, but in hospital we absolutely see fluids being given to almost everyone. If we give too much fluid, we can cause pulmonary edema. That's the reason that JACAB freaked out about it a few years ago and started telling you don't give fluid to anyone. We're now cautiously moving back towards it with a lot of considerations for many types of trauma and indeed medical hemorrhages, because we've realised that too much of this sodium chloride starts to disrupt the clotting cascade in the body, and it can actually break down established clots. So the way I think of it is every bag of saline has got a warfarin tablet dissolved in it. I just imagine that. It doesn't actually, but I have to think, right, if I give this person too much of this saline and they go too far the other way, I'm breaking down the blood clots that they've got. I'm going to make them bleed more, potentially. Plus, I'm only replacing their blood with a fluid that can't actually carry oxygen. So I'm very much an advocate of permissive hypotension. If I think the patient who's conscious is doing well despite their low blood pressure, I'll have the fluid ready, but I won't necessarily give it unless I think it's really necessary. Cardiac arrest is another story. You're past the point of, you're nearly past the point of no return there, aren't you? So a bit of fluid for your hypovolemic arrests, you're not going to make them any deader, and you might bring them back to life. I don't think I've got much. Oh yeah, and just talking here about the different ways you can give it. You can use a syringe attached to a three-way tap to measure the exact amount of fluid you're giving. So turn it towards the bag, draw some out, turn it towards the patient, pump it in. Do it in multiples of 10, 20, 50, whatever. Generally more helpful with paediatrics, but you may want to do this with your adults as well. Naloxone hydrochloride, or Narcan, trade name for it, I believe. This is an antagonist, which means it sits on cells and it stops the receptors from working in the usual way. And it's very effective against the opioid receptors. There's opioid receptors in many different places in the body. They do lots of very different things. Some of them regulate pain levels. Others happen to regulate the central nervous system. So non-selective opioid agonists can have very nice effects and not so nice effects. When we've got too many of the not so nice ones, that's when the Narcan tends to come out. It does not last very long. So if you're giving one dose of Narcan, be prepared to give two, and so on, if the patient hangs around long enough. There is this very lively debate about Narcan and how much we should give and when, and so on. I tend to advocate giving it only if absolutely necessary, using this sort of technique for your patients who are still alive. If I am giving it in an arrest, this doesn't really matter because there's not going to be a response probably. So I will just give a stat dose drawn into a 1 ml and pumped in. Sub-Q on the end is subcutaneous, by the way, in case anyone's wondering. But yeah, if we're giving it titrated to response, you draw 2 ampules, so you have a total of 800 mics into your 10 ml syringe, and then you draw up 8 ml of saline for a total of 10 ml of solution. So you have 800 mics in 10 ml. And you can give little doses of that, like you might have seen with morphine, little bits at a time, to see if that brings the patient up to the level that you want them at. The reason why we don't like banging in a big dose at once is because this can cause withdrawal symptoms, it can cause safety issues, because a lot of people aren't too happy about their overdose being reversed, because as far as they're concerned, they're just having a good time. And for those who are truly dependent on opioids, it can have drastic physiological effects and could cause seizures or cardiac arrest. So be careful with Narcan in your alive patients. For those who are in arrest, if you are giving Narcan, which may be futile, but we don't have a solid answer on that yet. If you are giving it, then a bit of Narcan stat dose into whatever line you've got is exactly right.
Does JRCAP guidelines and like SECAmb's guidelines say that you can do
condone the dilution thing?
Yeah.
So diluting a drug is a perfectly safe thing to do as long as you're using the right agent. So not all drugs like being diluted in normal saline.
Yeah.
Because it's a hydrochloride, it's absolutely safe to dilute it in as much fluid as you like. This is in JRCalc, and SECAmb's guidelines are follow JRCalc.
Yeah.
So the answer to your question is yes.
No.
But just for future reference, you can legally dilute any drug as long as you know that you're diluting it.
I just didn't know whether or not, like, obviously you're not giving, like, you'll be just giving a little bit.
Oh, I see.
more,
Right,
like,
titrating to
kind of-
response.
Yeah.
Yeah, JRCalc does condone that as well.
Okay.
Gunshot. Sorry.
Could we get like a 5-10 minute walk around break?
Yeah, I've got one more medicine after this, and then we can stop for a moment.
Okay.
Yeah. Cool. Glucose. This is a fluid, comes in a bag. You give it for hypoglycemia. Any questions about that? Yeah, so just a little thing about measuring blood glucose level. If someone can do it with venous blood, that's generally better than capillary for cardiac arrest, because the poor circulation to the peripheries means that they are artificially low on the blood sugars there. Bear in mind, the monitors we've got in SECAmb are designed for capillary only, so you shouldn't use them for venous blood. But if HEMS are there, they might have a venous blood machine, I don't know. And like I said earlier, it can contribute to cardiac arrest, unlikely to be the primary cause. Now that you're all freshly paced, welcome back. I'm glad that you said that actually, Charlotte, because I was thinking people look like they're hanging. So, yeah, cool. So just talking quickly about what causes the various cardiac arrest rhythms. We touched on MI as a cause for VF. That is the most common cause of cardiac arrest, and VF is the most common presenting rhythm. Those statistics are in hospital. Unfortunately, when we get to a lot of people, the VF has run out sometimes, but hopefully, every now and then, the response time model gets it right. So, on the left here, sorry, patient's left, on your right is some examples of shockable rhythms. At the very top is coarse VF. This is fine VF. It's not that fine, it gets finer as it goes on though. And then here we have monomorphic VT, where the QRS is not changing shape. And here we have polymorphic VT, so sensitive choir. That's the same one I showed before with the amiodarone. Who can see an issue with that and that? They look extremely similar. And if you see that on a monitor, it's going to be tricky to tell that from VF sometimes. Bottom line is, if you shock it, it's probably going to help. So don't worry if you miss a pulse check on a torsades. They'll give you a little slap on the wrist maybe, but one of the treatments for that is cardioversion, which is just defibrillation with less joules. So shocking that with a pulse, not the end of the world. And it's better to think something's VF, not me, than to miss VF, basically. Does everyone know about the gain reduction issue with fine VF on life packs? How it doesn't always look like VF on the screen?
Yeah.
So this is where the AED thing came from earlier. Fine VF, because of the way that the technology works on the life pack, sometimes looks like asystole on the screen. If it is fine VF, it won't look like fine VF on a printout. Right, so if you do turn up and it's sudden collapse in a VF candidate, you know, someone who's likely to have a VF arrest, consider hitting print before you do your rhythm check, and then get back on the chest, do whatever, but have a look at the rhythm strip once you've done the rhythm check. Just double check that it wasn't fine VF you were looking at a minute ago. Now, down on the side here, a couple of causes. After ACS, MIs and everything, I would say that arrhythmia is probably the most notorious cause for VF and VT, especially abnormalities to do with the QT interval, because this can cause the R on T phenomenon. Has anyone heard of that? Yeah? So R on T is the QRS happening at the same time as the T wave. R on T, that's literally what it means. But what does that represent in terms of cardiology? What does it actually mean is going on? What is the QRS representing? Ventricular depolarization, and the T wave, ventricular repolarization. So if an R on T is happening, what's going on with that heart?
Starting and resetting.
It's trying to depolarize and repolarize at the same time. You can't blame it for getting confused, poor thing. So R on T often leads to torsades, also often leads to VF. I think it can also just called good old VT as well. Certain drug overdoses, normally because of electrolyte abnormalities, can cause shockable rhythms. Surprise, surprise, most of these electrolyte abnormalities cause arrhythmias, which then cause things. So a lot of this comes back to arrhythmias. Hypothermia causes bradyarrhythmia, but also can independently cause VF due to interfering with the cardiac cycle, making the refractory periods too long and so on. And electrocution, including accidental defibrillation. Non-shockable rhythms. So above this line we've got some pulseless electrical activities. Third years in the room. One of you, what's this? So your cardiac arrest, patient doesn't have a pulse, what's this?
PA.
Yes, PA, yeah. If they... Alright. Who here is a bit of a geek for STEMIs and everything? Yeah, go on. Right, that was a hand. All right. So yeah, let's say this is lead 2. Again, you know, at the resus, there's no pulse or anything, but we see this on the monitor. What's going on here?
You can't differentiate. You still have to treat it as PEA.
Yes, correct. You do. What about this? There's no P wave and it's irregular. So what is it? It's PEA if there's no pulse. What about this? What's this?
That's a sine wave hyperkalemia.
That is a sine wave, thank you. It looks a lot like a SATS probe waveform, but actually this is an ECG printout. Severe hypokalemia causes the sine wave. Might be fast, might be slow, but you just get these ridiculous broad slurs. I'm pretty sure that's meant to be the heart's attempt at a QRS. But yeah, the electrical activity in that heart is just completely out of whack at the moment. There's no balance whatsoever there, and this person, if they're not in arrest, will be soon. So, if it's left long enough, PEA becomes asystole. If anything's left long enough, it becomes asystole. That's sort of a fact of life. It's a bit depressing. And then down here, I've just got an example of an agonal beat. So, you might go out to an obvious deceased patient. Quite commonly, you know, died at home. Not necessarily an expected death, but they've been found in the morning, ice cold, rigged and everything. You get your 3 lead on to confirm asystole, and then, oh, that pops up. For all intents and purposes, that's still asystole. Unless that's happening at a sensible rate, I would treat this as just the same as asystole. It's not, it's an agonal rhythm, but there's no coming back from that. That heart is just croaking. That's the heart.
Is that the same as junction?
Sorry?
Is that the same as a junction?
No, so a junctional beat will have some semblance of order to it. I like this one because that you can see where the QRS and T wave are, roughly, but there's nothing remotely normal about them. The characteristic of the agonal rhythm is it's extremely slow and it's extremely irregular. If you see this at your arrest and there's a CCP or something there, they're probably just going to roll it on the spot on this basis because there's little to no coming back from that. So for causes of what actually leads to them, immediate pulseless electrical activity, quite commonly with hypovolemia because there's no blood but the heart's still trying to move. It will tick over into asystole eventually, but you'll get that period of PEA. Hypoxia. Electrolyte abnormalities, again, they can just do anything to the heart. It depends on the type of abnormality and its extent. Tension pneumothorax, similar sort of process to hypovolemia, heart's trying to move, it just doesn't get the output. Cardiac tamponade, same thing. I've mentioned here that it can cause beat to beat, which is when you get a different shaped QRS with every beat. I've never seen that in practice. I don't know if it actually happens or if it's just one of those medical myths, but it's in all the textbooks, so I thought I'd throw it on there. Hypothermia would cause a very slow PEA, and it can be a desirable response to defibrillation because VF is less compatible with life than something like this or like this. The only problem now is getting that pulse back. Down at the bottom, commonest cause of asystole, death. Immediate asystole, so asystole that isn't preceded by PEA, I would only really expect that in really severe hyperkalemia. And this is the kind of situation where someone's been given a massive infusion of the stuff by accident, say in a community hospital or something like that, where they would just have no PEA period, they're just bang into asystole. And yeah, the causes of PEA can all cause asystole, but they do tend to cause PEA first. It's just a question of how quickly we get there. So, ROSC. A couple of key differences from this and cardiac arrest, mainly that you don't have to bounce on the chest, that's nice. Let's play a game. Bottom line, what's the difference? Is it a big difference?
The first one has had BLS.
The first one has had some BLS and it's been successful, yeah. Yeah, he's had a cardiac arrest. The other one hasn't. Are they both peri-arrest? If we think about how I defined peri-arrest earlier, so they're going to arrest if you don't do something. Are these guys both probably about to arrest without treatment? Yeah. This is a ROSC. A ROSC is essentially a peri-arrest. It's very rare that someone will bring a pulse back and then immediately back to full health, GCS 15, malarkey and everything. It does happen, just not very often. So your typical ROSC is going to look something like this. They're going to have rubbish obs, and if they hadn't just had an arrest, you would label it peri-arrest. So we use that ABCDE approach just like our peri-arrest patients, and we correct the abnormalities as we find them. When should we do the assessments? Immediately at the point of getting ROSC. And then, again, after you do anything major, so same process as when we're doing our cardiac arrest care, but also just every few minutes following ROSC. I would say at minimum you want to be doing this every 3 minutes probably. You'll probably find a reason to do it quicker than that. But if it's been 3 minutes, like you're on your way to hospital and you're just sitting there twiddling your thumbs, just do another A to E. You know, you haven't got anything to lose, just take a few seconds, have a look, listen at the head end, make sure that they're bagging properly, or ventilating properly rather. Have a glance at the monitor, check the rhythm, feel for the pulse and so on. So once you've done your immediate A to E assessment and you've corrected any abnormalities that you found, get a 12 lead done, make sure that your entire observations racket is going on. So we want something monitoring their heart rate, normally going to be defib pads. What's the problem with this and this?
Get in the way.
They do get in the way, yeah. So once you've done that 12 lead, if you don't need to do another one, get that paddle back on. It's a good way to monitor. Even if you don't think they're likely to go into arrest, if it's been quite a while and you've corrected the problem, it's a really nice way to monitor the heart because the patient's unconscious, they're not going to mind, and it's giving you a good vector of the heart, like lead 2. And the pads don't come off easily. ECG leads pop off all the time, but pads, they don't come off unless you want them to, or some idiot cuts through them with a pair of tough cuts. Waveform capnography should stay on regardless of what kind of airway you're doing. You can fit it to a BVM, so if that's the kind of airway management you've got going on, you can slot it in with a catheter mount. Get some SATs reading going, ideally with the pleth coming up on the screen, because that gives you a visible reading of the patient's radial pulse. You lose that pleth suddenly, either your probe's gone wrong or you've lost your radial. Blood pressure cycling. Does everyone know how to set up a cycling blood pressure on the life pack? If not, ask your mentors. Guys who haven't encountered life packs in practice, have a good play with them so you can figure out all the features and work out how to set a cycling blood pressure. Really useful feature. Take their temperature and measure their blood glucose. Probably a good idea to do the blood glucose at least twice after ROSC, once immediately and then once about 10 minutes later, just to monitor for any changes. And a little pupil check never hurt anyone. Treatment for them, only slightly different to usual. We're going to have a higher index of whether we need to RSI these patients. That's getting HEMS out to drop an anaesthetic. If they don't already have a tube in, if they do, CCPs can do the drugs, but they can't do it if they're not already intubated, unfortunately. They are probably going to want some sedation if we're managing their airway for them, even if they're not getting RSI'd, and again, CCP can help with that. They can do a bit of procedural. I think it depends on the extent of their airway problem, but a little bit of midazolam to ease them off a little bit. We want to aim for SATs 94 to 98. I have looked at the literature for this, and that does include COPD patients as far as I can tell. I don't think we're expecting many people who have chronic CO2 retainers to survive a cardiac arrest. But even if we are, we're in full control of their ventilations. So they're not going to lose their respiratory drive or anything like they would normally would with high flow O2. It might well be that later on in the hospital they decide to dial that down, but from what I can tell, the literature is leaning towards 94 to 98 for anyone and normal CO2. The rate correlation with the CO2 is inverse. So if you have a high respiratory rate, it's going to bring that CO2 down, and the opposite applies. So if you bag slowly, CO2 goes up. If you bag quickly, CO2 comes down. We want it to be normal. So adjust the amount that you're bagging in or the reading on your ventilator, and adjust the rate that you're bagging at appropriately. Go to 1 every 6, 10 breaths a minute. If that doesn't seem to be doing the trick, if the SATs are too low, if the CO2 is too high, bring up the rate a bit. Consider using a ventilator if you don't have one available. Talk about getting someone there who does, like a CCP or an OTL. Try and have at least 2 points of access in case you lose one. That's not usual practice for conscious patients, obviously, but this is the kind of situation where you need that access. A ROSC patient, I would argue, needs access a lot more than a cardiac arrest patient does. So try and have 2 points of access. IO is appropriate if they're obviously not going to feel it, otherwise there's that issue to consider. But yeah, one IV that's large at least, and if you can't get a large IV, at least one IO. Think about the drugs that you're going to give, so something for their blood pressure, some inotropes, atropine if they're going bradycardic, fluids to get the volume up, and specific to the individual cardiac arrest, you might want to look at naloxone, glucose, and so on. Monitor them, keep a firm eye on that ECG reading, and the minute they go into VT, feel for a pulse, if they do. Not everyone does, obviously, but if they do, fingers straight on a pulse point. Treat seizures as they present. Use your benzos, so diazepam is going to be the go-to. A couple of trusts are moving to midazolam, so you might see SECAmb do that in the next few years. We'll have midazolam instead. Hope so, it's a bit better. Hypoglycemia is easily treatable if you've got IV access. Less so if you don't. You can give iron glucagon or even some buccal glucose, rubbed very carefully. But yeah, IV glucose is my go-to for some hypoglycemia. You can give it IO. It's just an increased risk of osteomyelitis. So they can die of a hypo, or they can have an itchy bone for a few months. Target the temperature at 32 to 36. I think SECAmb just says 36, that's fine. But 32 at a minimum, that range is good. A little bit of hypothermia is actually really good for these patients. It keeps their brain going. And think about which treatment centre we're going to. So if it's an MI, where are we going? PPCI. If it's a traumatic arrest,
Trauma centre.
MTC. Yeah. Trauma centre maybe, but I would probably want an MTC, depending on journey time. Maybe. If you've somehow got a ROSC from a traumatic arrest, then yeah, the HEMS are probably going to be flying them. And if they're not already there, can anyone think of reasons we might want to fly a patient in ROSC?
Less bumpy.
Sorry?
Less bumpy.
It might be a bit less bumpy. Have you been in a helicopter? I mean, it might be. It depends on the pilot, I suppose, and the weather and things. Yeah.
Travel time.
Travel time would be the main factor here. I think what's more important with HEMS is the skills that the doctor's going to bring to the scene that aren't normally there. Flying a ROSC patient is quite a dangerous thing to do. It does happen, but we want to know that it's a really stable ROSC. And they're going to need to be flown with the Lucas on and the pads in place and everything like that. So it's a risky decision for HEMS to make. Plus, they can't bring a team with them. There's only 2 of them in the back. So, I did mention inotropic support. We can do this with adrenaline in the same syringe that we would give intra-arrest. 1 milligram in 10 mils, only we're going to be giving much smaller quantities of it. So this is definitely indicated within ROSC. Inotropic means something to do with pressure or blood pressure specifically. Muscle strength in this context with blood pressure specifically. Adrenaline does lots of things to the body, as I said earlier, but one of these is it squeezes the peripheries, it squeezes the blood vessels. So this brings up blood pressure and brings up the heart rate as well. You will probably see this being used post-ROSC. I've done this multiple times. And it does work. It works amazingly well, whereas intra-arrest adrenaline is probably into the wind a bit. Post-arrest, it's a wonder drug. There is some evidence that it's a good thing for septic shock and anaphylaxis. Anaphylaxis, generally only going to be a doctor doing that. Septic shock, there's a couple of EMS places around the world using IV adrenaline to treat it. Again, to manage that blood pressure. But this is not going to be code yellow sepsis. This is going to be a peri-arrest dying sepsis patient. So if I had one of those in front of me and I honestly thought this might be beneficial, I'd be on the phone to the CCD or top cover saying, look here, do you think I should do this? Because I think I should. And I just want your blessing, basically. If we are giving IV or IO adrenaline post-arrest, the first thing to do is see if it's feasible to get a CCP or HEMS there who can do an infusion instead, because little doses like this is good, infusion is better. Don't worry if they're not there. What we're going to do is get our syringe ready like we normally would, and a flush. And then we're going to go 0.5 to 1 mil of that 10 mil syringe, so 100 mics maximum. I think SECAmb will say use 100 mics, don't use anything less than that. Resource Council want 50, I think. So somewhere in between there is probably fine. Monitor the heart rate and the blood pressure. If the heart rate is above 100, then it's probably a good idea to withhold it for now. and obviously you want the blood pressure at a sensible level. In ROSC, 90 is probably fine. That's good. That's going to give you a MAP of about 65 or more most of the time. MAP is the average of the blood pressure versus the double diastolic versus half divided by the systolic or something. I can't remember how they do it. The machine does it for me. That's the little number you get in the corner with your blood pressure. So if that's above 65, that person's brain is perfused, generally. So a systolic of 90 is a good target to aim for with this. Any higher than that, we're risking overdoing it. There are obviously risks of doing this, among other things, subarachnoid hemorrhage is associated with a massive dose of adrenaline if you give that by accident. So be very, very careful with this. Only give as much as you need, but it is a very useful thing to do. It is absolutely condoned by SECAmb. They do encourage you to do it. I think they just want us to keep it to up to 4 doses of this. Although I've been under arrest with CCP and I gave over 10, and it worked fine. So you might encounter in placements and things noradrenaline and vasopressin or antidiuretic hormone. These are both inotropes as well. They're used to do the same thing for critically ill patients. Really, really popular in ITU. Probably most septic ITU patients are on some sort of vasopressor. Adrenaline is actually their last one that they will try. They'll tend to go for other things first. So adrenaline is definitely very good at this. It's just a bit less safe, potentially. So, I've talked a bit about HEMS and CCPs and so on, bringing advanced care out. We do call this advanced life support, but we have to face facts. In the paramedic world, we are a little bit restricted by things like culture and evidence suggesting that we shouldn't be doing certain things. We should leave that to the doctors. And simply money, sometimes. But here's what the Royal College of Surgeons of Edinburgh Faculty of Pre-Hospital Care expect of us. As a registered pre-hospital practitioner, you need to be BLS and ILS competent. You need to pass ALS.
Sorry.
That's all right. If you pass your degree, you will have passed ALS at some point. You might not have done the full qualification, but every approved paramedic program puts you through ALS training. That does include area management and drugs. You have to be able to manage the common trauma and medical emergencies and do some invasive procedures. So for us, that's needle chest, needle crike, and EJV, IO, things like that. Things that are a little bit more than just doing a cannula. This is not a complete list. The actual list is very interesting reading. I forgot to put it in my bibliography, I've just remembered, but I can direct you to that if you want. It's a really interesting list. Advanced pre-hospital practitioners should be capable of these things, among other things. So assisting with an RSI, it's a 2-person job, and the assistant needs to be specially trained for it. They need to be aware of how anaesthetic and sedative drugs work and how to use them safely for those purposes. They need to be able to perform a thoracostomy, cutting into the chest, using a chest drain or not using a chest drain. Mechanical ventilation, which is something that paramedics are capable of, which is using a machine to do the bagging for you, basically. Giving blood to a patient, not giving it to the blood drive people. We can all do that. We should all do that. Managing special circumstances, so this is the really rare presentations, the uncommon complications of maternity, CBRNE problems and things, stuff that we're aware of but don't necessarily go into great depth on our training. Added bonuses, this is basically HEMS doctor stuff down here, so doing the RSI instead of just being the assistant, doing a thoracotomy, which is cutting the chest open, emergency C-section, cutting a baby out of a dying woman, sonographic trauma assessment, which is using a portable ultrasound machine to look at the blood in the body or look at the organs in the body, and other point of care ultrasounds, so like scanning the chest. Are we aware that CCPs can do most of this? Yeah, they're not quite there. They're not quite on the standard for this level of advanced practitioner, but I think the only thing that comes to mind is that they don't do chest drains. This is optional, but they do all of this except blood and chest drains. And I'm sure they could give blood if they just had it with them. So let's talk about some of these roles. HEMS doctors normally work with the paramedic. They may have a third person with them, normally a paramedic or a doctor who's learning how to work HEMS. They are a 2 to 3 person team that deliver the highest grade of pre-hospital care in most places. They are usually the only access that patients have to RSI and thoracotomy. Critical care paramedics tend to work alone or on DCAs. They have some surgical procedures and everything depending on the place they work in. SECAmb CCPs, some of the best in the country in my opinion. Physician response, I don't believe this operates in this part of the country, but it does operate in London, and it's very popular up north, where you have a car-based doctor model rather than a helicopter. They can do basically everything that HEMS can, with a few exceptions. One of the main issues being that they don't always crew with a paramedic, so their assistant is not necessarily RSI trained and all that. It will vary heavily by location, as will all of this. Double paramedic HEMS is normally no more than a CCP or even less. I was made aware recently that double paramedic HEMS in one part of the country don't actually have a scope of practice beyond the regular paramedics, they just have a helicopter. Which is a bit worrying, to be honest. It's like because I go on holiday there quite a lot. So I don't want to crash. So let's talk about some of the procedures that these guys do. I've talked about RSI a lot, but I haven't actually explained it until this point. What it actually stands for is repetitive strain injury. It actually stands for rapid sequence induction. This is using an anaesthetic to stop someone breathing so you can take over completely. Well, an anaesthetic and a paralytic. It's used in hospital a lot for difficult surgical cases, but it's the only type of anaesthetic that you see outside of the hospital because all of the pre-hospital patients, they haven't fasted, they're normally unstable. They would be an emergency patient in a hospital if they're getting looked at by HEMS normally. So if they're getting an anaesthetic, it's an RSI. The difference being that you don't bag an RSI. So after an anaesthetic, those of you who've done theatres, they would have encouraged you during a normal anaesthetic, have a go with the BVM normally, because we get a bit of bagging done and everything, then they normally drop an eye gel. RSI is very different because they're worried about the stomach contents being aspirated because the patient hasn't fasted. There's normally some pressure on the cricoid ring to stop regurgitation. And the next thing that goes into the patient after the anaesthetic and paralytic drugs is the bougie, followed by the tube, or the laryngoscope first, presumably, unless they're a really good intubator. And yeah, like I mentioned, you do need that competent assistant to RSI assist. I'm pretty sure if I had to, I could assist with an RSI. It's just a really big non-technical skill because the communication is really key. Has anyone witnessed an RSI?
Yeah.
Yeah, HEMS doing an anaesthetic outside of a hospital?
Yeah.
The communication is incredible. They get complete silence if they can, and they verbalise everything, every last little thing.
Textbook sequence.
Yeah, go on, mate.
When is the difference between burp and cry pressure used?
So burp is backwards, upwards, rightwards pressure, and this is manipulating the entire larynx in those directions. So backwards, upwards, rightwards. Because the laryngoscope light is on the left-hand side of the mouth, you're moving the trachea over to the right, backwards and upwards as well. This is to increase the view of the chords, basically, for the person holding the laryngoscope. Burp, so that's burp. Cricoid pressure is very different. This is using the cricoid ring only, which is just below the cricothyroid membrane, and pushing it backwards. And in theory, what this does is it occludes the top of the esophagus. Whereas burp is moving the airway, this is you're trying to move the esophagus. And that way, the thinking is if they regurgitate, the pressure here stops the stomach contents from coming up into the pharynxes and obstructing the view of the airway or causing aspiration. There's an amazing video on YouTube, Hines versus May, about cricoid pressure, and I highly recommend it. It's very entertaining. So if you just look up Hines versus May cricoid pressure, that's definitely worth a watch. Surgical airway. I always think of this as like the key to success with emergency airway management because the scalpel goes in and it rotates like a key. The cricothyroid membrane in the middle of the neck is perforated and then dilated, usually with a fingertip or even just a bougie or something, and then a tube is passed over it through the hole into the neck. This is done when nothing else is working to manage that airway, or when the only thing that is working is BVM and that's inadequate for whatever reason. There's some very interesting literature out there about this, including many cases in which it's been done inappropriately. Currently, this is not in the standard paramedic scope of practice, or whatever you want to call it. It's not considered a generic paramedic skill, but I'm of the opinion that it absolutely should be, because I've done a lot of reading and research around needle cric, and I think that if we're doing that to our patients, we're violating Hippocratic principles. We're harming them more than we're helping them. When surgical airway is as easy and safe as it is, and it is a very easy and safe procedure, frankly, ambulance services have no excuse. It's cheap, it's safe, it's easy. The concern that has been raised is that one trust that is doing it already, the paramedics are doing it too often. But if even one of those cases was someone with failure, an absolute failure to intubate and oxygenate, then it was done appropriately and it's the right thing for that patient. So I'm very much in favour of this being a paramedic skill, and I think it will be. Just give it some time. So at the moment this is limited to CCPs and HEMS, at least in this area. There's not much we can do to prepare for it, apart from just try everything. So if you can't intubate, try your iGel. If your iGel doesn't work, try all your basic airways. If they don't work, take them out, just try the BVM. And strictly speaking, we should try needle crike as well. I'm just going to, spoiler alert, it's not going to work, but you should try it, basically. I'm not going to tell you how to do it, because there is no right way to do it. Thoracostomy. Ostomy is making a hole, thora is thorax. So thoracostomy, making a hole in the thorax. So this is done to relieve massive hemothorax and tension pneumothorax where other therapies aren't effective. Decompressing a chest is probably not going to help a hemothorax, so it's definitely required for your major trauma patients with chest injuries and so on. They need to be ventilated under quite high pressure for it to work, but essentially what happens is when the blast of oxygen or air goes in, it pushes the lungs up and the stuff that isn't meant to be in the chest comes out of the holes. Really like simple physics going on there, but it works. It's very effective. A chest drain is used when they're thought to be continuously bleeding into the chest, or there's a lot of stuff to get in. There's a lot of stuff in the chest that needs to be gotten out. So a chest drain is a tube that's put in and set to suction and just pulls everything out that shouldn't be in there. Currently, this is done by SECAmb CCPs intra-arrest for asthma and trauma patients, and HEMS can do it electively because they can RSI the patient if they aren't already in arrest. Yeah, that's all there is to say about that, really. Thoracotomy, similar names. Thoracotomy and thoracostomy, very important difference. Thoracotomy is the joining of two thoracostomies to create a long incision across the chest. A massive pair of scissors are then used to cut the sternum in half, and the chest is open like a cardboard box. It is the most invasive thing that has ever been done outside of a hospital in the name of medicine, and it has saved many lives and brought them back to a very good standard of life, quality of life. The reason it's done is because in chest trauma, you don't have access to the heart, you don't have access to the lungs, you don't have access to the aorta and the vena cava. Vena cava. Is that how you'd say that? I don't know. If you cut the chest open and lift it, you've suddenly got access to all of these things. This is the only thing that's going to help cardiac tamponade, cardiac arrests for trauma. It's the only thing that's going to help a lot of penetrating chest trauma. Enough so that it is immediately indicated. If you suspect that someone's in arrest following a stab wound to the chest or back or epigastrum, then HEMS is basically the only chance they've got, probably. Once the chest is open, they can repair things with sutures or just direct pressure, and they can cross-clamp the aorta, which involves putting something over the aorta to stop blood flow going below a certain point. This allows blood to be in only where it's absolutely necessary, basically. Legs might fall off, but it's worth it. Probably not, but yeah. Similar to that is REBOA, resuscitative balloon occlusion of the aorta. I've missed a word there, I'm very sorry. Resuscitative endovascular, that's the E, balloon occlusion of the aorta. So this is done by London HEMS, and I don't know about other HEMS, hopefully this HEMS, but I'm not sure. And this uses the femoral artery to guide this long wiry thing up into the aorta and then blow up a little balloon, just like a cuff on an ET tube. Only it's doing something very different. It's blocking all the blood flow below a certain point again. So this is really helpful for your pelvic fractures, or someone like this who's got massive lower limb injuries that aren't being controlled by other means. And it keeps blood where it's most needed. So yeah, that's what REBOA is. That's one device that might be used to facilitate REBOA. And if you're at the scene of a pelvic fracture who's going really downhill, then this is something that you might see brought out of the toolbox. extracorporeal membrane oxygenation, or ECMO, otherwise known as extracorporeal life support in this context. Has anyone heard of this? Put your hand up if you've heard of it. That's good. I wasn't expecting that many. That's really good to see. Have you heard of it from uni or from something else? Yeah. So what it actually is using central lines to take blood out of the body, oxygenate it in this amazing machine, and then put it back in. And the advantage of this is it lets you stop CPR. You basically don't have to do anything to keep this person alive once this is on, because it's doing all the work for you. This is used for cardiac arrests that aren't responding to normal therapy, but are likely to recover if we treat the underlying cause. So, for example, refractory VF in a youngish person that is just not going away with shocks. We've tried adrenaline and amiodarone. If we get ECMO going, it lets us resuscitate them for longer and with more efficacy, because they get a normal, well, a near normal amount of oxygen and everything in their blood, whereas CPR only provides a limited amount. So this allows resus to go on for much, much longer than normal, with a reasonably good chance of survival. It's being used by a few HENs around the world, none here yet, fortunately. However, there are research projects going on. If you respond to a call at Brighton or London Marathon, there may be an ECMO team there, and certain hospitals are set up to receive patients from HENs for ECMO. I think it just has to go through HENs because that's the pathway, so they might do it through top cover. I'm not too sure, to be honest.
London started it last week with St Bart's. So if you're
Pre-hospital ECMO.
They've done
I
it.
did read that they were going to,
Trial.
yeah.
It's on a trial, but
Yeah.
basically they're doing the city of London's around St Bart's.
Yeah, so I've got the, that's in my bibliography, the plan for that. I didn't realise it started though.
Last week.
That's good.
With a lot massive.
Yeah, that's really good to hear though. So if you're going to have a cardiac arrest, have it in central London. The big issue with ECMO, and the bit that we can help with, is selecting the right patients for it. So I'm not going to go through it here because I'm not an expert in this, and it's quite a big topic, but read around ECMO, have a look at Ben Singer's work, and see if you can find out a good set of criteria for patients who are likely to respond to ECMO, and then get on the phone and discuss it with CCD. Just say, this guy might be a candidate for ECMO, do you think we're playing ball here? And yeah, if it's a reasonable time to the ECMO hospital, great. But that is the big issue, the selecting the right candidates for it. So just a few more medicines that you might see popping up in ALS. Benzos. Diazepam should be with every paramedic in an ambulance, unless they've forgotten to use the Omnicell that day. Midazolam and sometimes lorazepam might be seen in the hands of advanced practitioners. So these are central nervous depressants, and they're really good for treating seizures, but they're also used in anaesthetics and sedation for their sedative properties. They calm down muscle movement, they calm down the central nervous system. Because they calm down the central nervous system, they can cause CVS depression and respiratory depression as well. So they do need to be extremely closely monitored, and do use your nasal CO2 on these guys. When we're giving diazomols, which is the white form of diazepam that we have, it's like a milky stuff in a little ampoule. It goes into a 2 ml syringe and goes IV or IO, doesn't go AM. It's not strong enough to go AM. And we want the monitoring on, BVM ready, and just keep a really close eye on these guys, make sure that respirator isn't dropping off. Diazepam does last quite a long time, so that monitoring doesn't generally come off. Ketamine, this is dosed by the patient's weight of all age groups. And it's amazing, it's got lots of different uses. It's a pain reliever, it's sedative, and it's an anaesthetic. So is morphine, but that's a lot less safe. Ketamine is probably the favoured drug for all these pre-hospital applications because it's cardiostable. So for your major trauma patients and your cardiac arrest patients and everything, ketamine's a really good anaesthetic drug. It's also used for procedural sedation for cardioversion and pacing, for example, like we mentioned earlier. And it might be brought out for setting fractures and so on. I am not going to give any advice on giving this drug because I can't give it myself, I'm not trained to, and it's not Schedule 17, so it's not something that every paramedic carries. It's only for those who've signed PGDs bearing ketamine's name. Rocuronium is used in conjunction with anaesthetics to paralyse the patient. So paralysis in this context means stopping muscles from moving. Conveniently, the only muscle it doesn't do this to is myocardium. So the heart keeps beating, but everything else stops, including breathing, which is the desired effect of this. What this means is that there's going to be no resistance from the patient while they're trying to intubate, which is why they paralyse them, and then they've got full control of their respirations afterwards. Rocuronium has a very long half-life. It's at least an hour, very long relative to other paralytics, which normally last up to an hour or 10 minutes, even for the quickest one, I believe. There's no point of giving it during cardiac arrest generally, although there's been a bit of interest in CPR-induced consciousness, and these patients potentially needing RSI intra-arrest, which would be developing area of medicine. The big risk is obviously that they will die if you don't manage their airway. So a CCP is not going to give this if there's not someone there who can help them manage the airway, i.e. a paramedic who knows how to assist with tubing and so on. If it's given before an anaesthetic or without an anaesthetic, the patient remains fully aware. If they were fully aware before, they will be fully aware until they're dead. So when you hear about people waking up in surgery and everything and they can't do anything, it's because their paralytic is still working but their anaesthetic is worn off. So the sequence during anaesthesia is always anaesthetic first. I've heard one very bold doctor, who's sadly no longer with us, but he's a brilliant man, saying that there is occasionally a reason to do this without an anaesthetic, but not something we'll be managing, obviously. Again, not Schedule 17 drug, needs PGD, and not standard paramedic drug by any means, but is carried by our CCPs. Calcium chloride, I mentioned this earlier. What's it used for? I don't know if it says on there. Hyperkalemia. Yeah, hyperkalemia or hypocalcemia. It corrects the imbalance between the two. Intra-arrest, this can reverse a hyperkalemic arrest. Peri-arrest, it's an absolute must. How might we recognise hyperkalemia in the pre-hospital setting specifically?
In arrest or at all?
Before their arrest.
PKT whips.
PKTs, maybe. Lots of other changes, but yeah, basically a screwed up ECG, especially the T wave and the QT interval and everything. Looking around that end of the couplet. Someone who's got that suggestive history and they've got a really abnormal ECG, then yeah, they're potentially going a bit hyperkalemic, and PKTs is one example of that. It can cause ischemia, apparently, but there is some opinion out there that this is a load rubbish and it might just be a perfectly safe drug. Personally, I don't really think it matters. I think if we're giving it to the right patients, then it doesn't matter if they get a bit ischemic, they just need it. It is not Schedule 17, unfortunately. It is considered a standard ALS drug in hospitals, and it is on every resus trolley, but it's not in every ambulance, and I would like to see that change. But because it's not exempted for paramedics, you won't find it on every ambulance, but you will find it in CCP cars. So if we add some advanced care to our earlier patients, we can see the kind of difference that this sort of thing makes. So in our asthma patient, the lady who's been unwell for a few days and so on, I've said here that we weren't able to intubate her. The IGL worked for a little while, but there's no chest rise because we keep on decompressing her chest and it just doesn't seem to be doing anything. CCP turns up, he's able to keyhole the neck, get a tube in through there, and thoracostomy her because he's got that tube in. He can do the high pressure ventilation, relieves the bilateral pneumothorax and gets a ROSC. He's then able to do the anaesthetic because he's got a tube in place. So he gives her some ketamine and gives her some rocuronium. Added bonus, ketamine's also a bronchodilator, same as salbutamol. Just does everything. It's also the cure for depression apparently. But, you know, I'm not sure I'd recommend self-medicating. So that's a very feasible example, I think, of how a CCP can really change someone's prognosis using what's available to them at the moment. VF. VF is Ben Singer's favourite indication for ECMO, it seems, from reading his literature. So I've made this an ECMO scenario. We've got refractory VF here. We've probably been going for about 10-15 minutes at this point. But he's got spontaneous movement. He's getting some CPR-induced consciousness. HEMS are able to sedate these patients, and then if he's recognised as an ECMO candidate, get him over to the ECMO centre. Yeah, I think that this is pretty amazing stuff. These guys are on the cutting edge of pre-hospital medicine a lot of the time. We've got an amazing CCP team that I'm very glad to have in the area where I work and live, and I'm very optimistic for the future of pre-hospital care in this country as a result. So there's tinfoil hat. Here's what I think might happen in the future. Within the next 5 years, we will be getting new ROSC guidelines, probably next year. I think ECMO is going to be available in more places, and probably pre-hospitally on a more wide basis than just Greater London. I think there will be some more literature about naloxone out. In the USA, they're having an opioid crisis. Everyone's on prescription opioids, lots of people doing heroin, dying of overdoses. Everyone's given Narcan auto-injectors. Everyone's terrified of carfentanil. There's so much hysteria about it. The only outcome I can see is research being done. Don't know what that research is going to say, but it will help to further our understanding of Narcan. There's going to be some changes, I reckon, with adrenaline and amiodarone. Maybe not this time round, maybe a bit in the future, but I think there definitely is more research ongoing at the moment, and there will be more coming out, so keep an eye out. I think we're probably going to have surgical airway in our hands. 5 years is probably optimistic, but I reckon it's coming. Within the next 10 years, the beginnings of, you know, I'm trying to think of the word, when you can just about see a whale about to explode from the surface. Hydrocortisone, that's a drug that's normally reserved for anaphylaxis and endocrine emergencies. There's a bit of research, not much, that it might improve outcomes in cardiac arrest. So we might see that make its way into our ROSC guidelines. Pre-hospital blood is going to be available in more places, I think, because the research is just showing it's such an amazing thing to have. I wouldn't be surprised if some CCPs are carrying it around the country in the next 10 years. The issue is going to be acquiring it, because we're always short of blood in this country, unfortunately, and it has to be O negative if it's pre-hospital, which is one of the rarest blood types. Pre-hospital apnea oxygenation might come in. There is, again, burgeoning research going on where people aren't bagging their cardiac arrest, they're just blasting oxygen into their lungs, and it's actually working really well. Been done quite a lot in surgery. I think it's happened a few times in cardiac arrest and been really successful. It's just about finding the right patients for the treatment. So yeah, if you ever see a CCP slap CPAP on a cardiac arrest, then that might be why. Or they've gone insane. Finally, I think procedural sedation is going to be more widespread. We might, with the rise of midazolam, we might have procedural sedation come into our scope of practice. I would not be surprised if in some places we get paramedics performing RSI. However, I equally wouldn't be surprised if it never happens. I think if it does, it will happen in the next few years, or probably not this century. Has anyone got any other thoughts about what might happen? Any research they're aware of that's going on? I love talking about this sort of thing, so if you've got any thoughts, I'm really keen to hear them.
Borocostomy being paramedic.
Yeah, that's a good point actually, because now that it's a CCP skill, it's quite simple, it's quite effective. So yeah, I think intra-arrest finger thoracostomy, I could definitely see that. It's already in a lot of places in Canada and the USA, so maybe I'll put a 10-year on that probably. Any others?
My mentor's convinced, do you know Chloe Thornton?
Oh yes,
Well,
I love Chloe.
mentor.
Chloe's great.
She said that in Australia they use salbutamol for crush injuries.
Oh yeah, so does anyone know why that might be?
I can't remember what the reason was.
So salbutamol stimulates the release of insulin. You should always check a patient's blood sugar after a large dose of salbutamol. And part of that is it shifts potassium out of the circulating volume, so it treats hyperkalemia. Again, not a listed indication in our guidelines, but common practice in other places around the world and in hospital, salbutamol for hyperkalemia. So crush injuries, absolutely a candidate for that. Yeah, that might well crop up in our guidelines. We'll see. The other one is nebulized adrenaline. That's not in our guidelines at the moment. Legally, you would be sound if you gave it as a paramedic, but Ambulance Trust would not be very happy with you doing that. Yeah, nebulized adrenaline, very good for croup and asthma, but not in our general practice at the moment. Are there any other questions?
I've just got one really quick one.
Go on.
Refractory VFVT, when do you start thinking it is? Has it a certain
I would say if I've given 3 shocks and it's not working, I'm starting to think, right, this is refractory, because that's the listed indication for amiodarone is refractory VF, and I agree that at 3 shocks it's appropriate to go down that route. If anyone's wondering about this, this is a film that actually exists. called Any Questions from Ben. I haven't seen it. I didn't know it existed, but yeah, thought that was pretty useful. And it's available for non-commercial reuse on Google Images. So, just to summarise, we've gone through what BLS, ILS and ALS actually are, the stuff we need to deliver ALS, put it into context, looked at reversible causes and how advanced care might work, and gone over a few ideas for what might be coming in the future. There's a little bibliography. This is the article I mentioned about ECMO by Ben Singer and his crew. And there's some recommended further reading for you if anyone wants to take a snap of that. That's stuff I'd recommend.
Sorry, Ben, what's that about hydrocortisone in insurance?
So I don't have a reference for that because I couldn't find the article, but I have read at least one article about giving it during, in fact I think it was Japanese BLS ambulances were giving it during arrest and they were finding an increase in ROSC. So the way hydrocortisone works is it stimulates the body to release adrenaline. So it's essentially giving indirect adrenaline. It's just potentially a bit safer than giving big boluses of adrenaline because it has a more gradual effect and a more regulatory effect on the blood pressure, rather than just spiking the blood pressure and letting it wean off like adrenaline does. If you give hydrocortisone, it keeps it up, in theory. That's why we give it for anaphylaxis, and it's part of why we give it for, well we don't, but some people give it for sepsis for the same reason. So, that was ALS. I hope you all enjoyed that. We did say we were going to do ECGs tonight as well, but we are coming up to 8 o'clock and we're not going to get this done in 15 minutes, unfortunately. What I can do is I could try and record this as a video and send that to you guys. I'm sorry that we didn't get a chance to go through it, but maybe I'll be back here at some point and be able to do it then. While I'm here, does anyone have any burning questions about ECGs, if they want me to go through anything quickly?
Basically, video it will come back.
Yeah, I'll do what I can for that. I'm no expert, but I'll see what I can bring up for you. Thank you all very much for your time. I've really enjoyed being here.